Well, I'd like to welcome you to our 5th annual culturally centered, in the new iteration, it's community centered, addictions research training. We managed to keep our acronym the same, CCART. So we're really excited that you're all here. I also want to welcome you to the College of Education. This is my home, Shane's home, and and this beautiful space that we get to spend today and hear about the research our scholars are doing. And just want to welcome all of you, welcome our community partners, welcome scholars, and some of our returning scholars, and guests, anyone who's here, and our faculty, of course. As they say, the overused phrase, it takes a village to make all this happen, and it sure does. We are so grateful to everybody, including our staff, who are here to make sure everything goes smoothly. We walk in and everything is set up, and it's so wonderful. So thank you, all of you, Nick, Shannon, Amy, and everyone else who has worked on this project. So, before we go any further, I would like to go ahead and do a land acknowledgement. As you know, Northern Arizona University sits at the base of the San Francisco Peaks on homeland sacred to Native Americans throughout this region. We honor their past, present, and future generations. Who have lived here for millennia and will forever call this place home. I personally feel very, very grateful to be at this place. I've spent 35 years here in Arizona, in this beautiful land, and I'm very, very grateful to the Native Americans throughout this region who have just, this has remained a beautiful place despite the buildings and things like that. And the fact that we do research that is culturally centered is also so meaningful that we're doing it in this land. So I'm going to turn it over to Julie.
Okay, well, again, it's so wonderful to have you all here. Oops. And I went way too fast through the whole presentation.
Faster than it.
Oh my gosh, that really went fast. Okay. Okay, so because there will be a number of people speaking today, we won't have everybody introduce themselves at this time. So when the groups come up, the scholars and the faculty and the community partners who are part of those groups will introduce themselves. But we do have a few guests that we'd love to know and who you are, and tell us a little bit about yourselves that won't be those who won't be presenting today. So if there's anybody not presenting today, raise your hand and maybe please introduce yourself if you don't mind. Yeah.
Hi everyone. I'm Dajoni Scott. So she Dajoni Scott Yanishia. Bipatorni Nishle, Ayakini Bashichin, my Dishkini Dashache, Ayakini Dashanelith. We just had a great land acknowledgement. As you meet me, you meet all of my ancestors. I work here at NAU Counseling Services as the Substance Use Disorders Coordinator. I'm also an LPC licensed professional counselor and maybe a potential person in the program. I'm going to put it out there. Thank you all
so much.
Thank you.
Thank you. And are you visiting too?
Yes, yeah, my name is Stephen Devil. I'm a nurse leader over in the emergency room at Flagstaff Medical Center.
Okay, welcome.
We also have Sandra.
Sandra's not presenting today either.
She's not presenting.
Yeah.
Oh, okay.
Introduce yourself.
Hi, I'm Sandra. I graduated last year from this program, so
Yes.
I didn't think I'd have to introduce myself.
It's great to have you back. And Emery, are you presenting today? You want to introduce?
My name is Emery Eves. I'm a medical anthropologist professor here at NAU, and I have been a mentor in the past, but I haven't.
Emery. Sabrina?
Yeah, hi, hello, Sabrina Ostoy. I'm a professor in the School of Social Work at ASU, and I'm so happy to be here and so glad that you invited me to come and looking forward to your presentations.
Thanks, Sabrina. And just so you all know, I think many of you heard last night at our session that we're really hoping our grant's going to be renewed for 5 years. It's going to be reviewed on Monday. And if it is, Sabrina and her team from ASU will be joining us too. So we're really excited about that. I know there's some other guests, if you want to introduce yourself.
I'm Tila. And I'm just supportive.
Thanks so much.
Wonderful.
Yeah, thanks so much for being here. Anybody, you guys are all presenting, right? So we'll wait. And then Amy and Nick, maybe want to say a word? Anything?
My name is Shannon Steele. I'm an active program coordinator for CCART of Education. A lot of you had email correspondence with me, so I should have at some point had a conversation with you.
I'm Nick Beckett. I'm the events coordinator for Share. Y'all met me last night if you were at the workshop. I primarily put those ABRC workshops on each year, but I'm also just willing to help out with any events that Share or Share puts on.
Thanks, Nick. Ella.
I'm happy and just make conclusions. She's here and then please capture the.
Thank you. And Beck too.
Hey everybody, good morning. I'm Beck Thomas. I'm the communications manager for Share.
And we have.
Yes, we're
Oh,
just
I'm
doing.
just a participant, or are we doing,
Okay,
yeah.
Yeah, we're introducing those that are guests.
Oh, okay.
Yeah.
Jessica Holton, clinical social worker, live in Flagstaff, but have a private practice in North Carolina.
Fantastic. So I think we got everybody who's who are our guests today. Thank you again for being here. And then for those of you presenting again, please, when you come up, be sure to introduce yourselves. And so this is the agenda for the day. We will start with one of the groups presenting. You can see the schedule here. And then we will have actually a short break after that. And then another one of our groups presenting at 10:10. At 11:05, we have a community partner evaluation survey that we want to do at that time. Then we'll have lunch, and then we are fortunate to have a keynote speaker here today at 11:45. He'll be joining us then. And then we have one more group presenting after a break around 12:50. And then a very short evaluation. The Arizona Biomedical Research Center is helping to sponsor this event. And so we do need to do a short evaluation for everyone that's here. And then we actually, most of you are free to do other things for the afternoon. We are having a reception. We'd love for you to come back for the reception at 5 o'clock. But in between about 1:40 and 5 o'clock, there'll be some other activities specifically for the scholars. So some focus groups, another responsible conduct of research session, and some more evaluations. So please do come back though at 5 o'clock. So the reception will be back over at the High Country Conference Center, not the room where we were in last night, but across the street from that. So I think that pretty much sums up the plan for today. Are there any questions, comments before we get going? Okay.
And the restrooms for those is just straight down the hall on your left. So that's always a question people have. So.
All right, so I'll invite our first group to come on up and get ready. And for those of you who would like to sit in the chairs, you can, and we can pull up some more chairs too. So community partner as well, if you can please come up, that'd be great.
Chair.
Okay, hi everyone. Maybe we can just do introductions first. My name is Tiffany. I'm currently a second year in the doctoral clinical psychology program down in Phoenix. So yeah, that's me, and I'm one of the students.
My name is Brianna. I'm an occupational therapy student in my third year, graduating in just a couple weeks. Very excited. I feel like I want to make mention of Gabby. Gabby Record is unfortunately not joining us. She was part of our group. She recently graduated from the physical therapy program. Okay.
Morning, everyone. I'm Shane Haverstra. I'm a professor in educational psychology, one of the co-mentors of this awesome team. So really, it was a pleasure to work with you all. Stand up too.
Thank you.
Good morning, everyone. My name is Michelle Muro. I'm with Southwest Behavioral and Health Services, and my primary responsibility with the agency is our outcomes management, as well as supervising our future clinicians, licensed clinicians. I'm an LPC, and I've been with SDH, started as a therapist way back in 2002. So I'm really happy to work with this wonderfully talented team, and then also with Dr. Habistra and Dr. Roddy as well. Thank you.
Hi, good morning. My name is Julie Roddy. I'm in the Department of Criminology and Criminal Justice, the Workler Chair there, and a professor, and one of the faculty members of this wonderfully talented team. So I can't wait to see the presentation.
Okay, so first, I just wanted to talk about our wonderful community partner, Southwest Behavioral Health and Services, and speak a little bit about what they do. So they are a community health, mental health organization, and some of the services they provide are outpatient services, services for substance use treatment, as well as providing housing for those in need. And one of their foundations is really providing accessibility to the community. And some of the ways they do that is collaborating with, CCART and doing some research, and they provided us with some they provided us with some archival data, and we were able to look at some of their outcome measures, and yeah. Okay, so one thing that they also really value is patient-centeredness. And patient-centeredness is the incorporation of the patient's values, preferences, and overall personal needs into their treatment plan, which can be very important. And research has demonstrated before that it not only improves the patient's satisfaction with the treatment, but also overall outcomes and their adherence to treatment, which is especially important in substance use, as there's a myriad of factors that contribute to treatment adherence overall. And being able to take into account some of their external factors that are impacting their ability to adhere to treatment is extremely important. Things such as like what's going on with their family, are they able to find housing, which is some of the things that Southwest does provide. And I also wanted to talk about the ASAM, which is an intake tool that providers use to determine levels of care. And as you can see, there are 6 dimensions that providers will kind of go through with the patient as they're talking about what sorts of things they are needing in treatment and developing a treatment plan with them. And one of the dimensions is recovery and living environment, which kind of ties in with that patient-centeredness, because they take into account what sorts of things will contribute to their recovery in their own lives, and also how is their living environment overall and how does that contribute. And it's really important to look at the ASAM as well, because it is something that some insurances require and Medicare requires when it comes to when it comes to reimbursement and things. And so when we talk about accessibility, Medicare is something that a lot of people use for their insurance and try and receive healthcare services. So, okay. And some benefits of the ASAM. So the ASAM has increased patient transparency, and overall, patients are more likely to endorse symptoms to their providers that are accurate to their actual presentation. They also have reported that they felt better equipped because it's more of a conversation. And so patients are more likely to, feel better, like, okay, this is where I'm going. This is what treatment I'm going to receive, instead of just being kind of sent into a random treatment facility and not really knowing what's happening, which can happen sometimes when bias comes in with treatment providers, unfortunately. And some of these effects were consistent over different counties with varying characteristics, such as different poverty levels and things. So that really underscores the generalizability of the tool and the importance of kind of looking into how effective it can be for different populations. Again, speaking to that accessibility piece. However, with benefits, there are always critiques. And so there are significant variations in the administration of the tool and overall clinician judgment. And so 68% of providers actually disagreed with what the ASAM decided was their appropriate level of care. And also providers reported a range of questions that they asked during the using the ASAM, ranging from 15 to 328 questions, which is a very large range. And so I could imagine that those who asked 15 questions maybe didn't really get in too much detail about that recovery and living environment piece versus someone who asked 328 questions. And this was a qualitative study, so a lot of the providers also stated that they felt just using an intake tool alone wasn't always effective because sometimes patients are very hesitant to share what their actual symptoms are because they're afraid of being stigmatized by providers. And their feelings are unfortunately a little true because another study has also shown that women and white individuals were more likely to receive higher levels of care than they actually needed compared to men and Black individuals who were less likely to be recommended services at all. So, yeah. Oh, wow. Okay, hold on. Okay. And so, like I mentioned earlier, because these treatment providers said that they have a tendency to underreport their symptoms, it's important for us to, come up with ways that maybe we can really get a true, accurate picture of what the individual is going through so that we can provide them with accurate treatment. And research has shown that self-administered questionnaires are actually more likely sometimes to capture accurate patient symptomology, probably because you don't have to actually be engaging with social interaction with someone so that maybe bias or feelings of stigmas are alleviated and you're able to just fill out things on your own. And so Southwest Behavioral Health does have a tool like that called the TWOS, or the Total Wellness Outcome Scale, which asks patients over a period of time their own perception of their health and social determinants of health, which kind of also speaks to that recovery and living environment and all the social aspects and factors that are contributing to how their health is presenting. And then also their presenting concerns and how they feel overall with the progression of their treatment. And so I will send it over to Gabby, who is on a recording, to talk kind of how all of that information ties into our purpose and our research questions as well. I don't know if
Maybe it should play it.
Perfect.
We clicked it once, just a second, go back one.
Oh.
It's a tricky clicker.
Oh, okay. That one?
Yep, perfect. So I think it's worth mentioning as well that we are taking over. There was another group for us, another CCART project that looked at the validity of the TWOS. I think that's worth mentioning in this instance. And so that's why we're taking this measure that Southwest Behavioral Health Services already created. And we already did the research on the validity of that. And we looked at the intersection of that with one that's required by Medicare, insurance, all those things. So I just kind of wanted to clarify kind of why we're doing this. But then the juice of it. So the results that we have, we analyzed data, like Gabby said, from 443 participants. When looking at the descriptive statistics and overall mean change of what we have, it's worth noting the positive change in TWOS. So we see that participants are continuing to demonstrate improvements on this measure throughout their treatment. This is important because it shows that the intervention environment itself is supporting perceived progress, even before we look at the predictive relationships. No worries. So then in terms of our simple linear regression, that's what we use to examine whether that improvement in the TWOS score actually predicted clinician relapse risk. What we found is that essentially there's no meaningful linear relationship between change in TWOS score. The scatter plot shows points that are pretty widely dispersed, and then the line is pretty much flat there. The R-squared value is 0.003, which indicates less than 1% of the variance in relapse rating is explained by changes in TWOS score. So clinically, this tells us that even though patients are reporting feeling better, that improvement does not help us predict how clinicians are going to rate them in terms of relapse potential. Perfect. So then we wanted to look at moderation as well for this. So from the data that we had available from Southwest, we also felt it would be meaningful to see if race moderated the relationship, which unfortunately, as we can see, we did not see any relationship there, suggesting that there's a lack of predictive relationship between twos, and relapse risk is also consistent across racial groups rather than being driven by relationships between the groups. We wanted to make sure that there was no underlying relationship there as well. So then the result summary, basically saying the same things. The regression model is not statistically significant. The twos change explained approximately 0.3% of the variance in relapse ratings, showing negligible predictive power. Change in two score was also not a significant predictor of relapse rating at discharge. But the positive coefficient does suggest a slight increase in relapse rating with higher twos change, but that relationship was trivial and non-significant ultimately. And then the overall moderation model as well, not statistically significant, only explaining 0.048% of the variance in relapse rating. So again, no significant moderation there. So the discussion, that's really where we can get into a lot of things here. Because one of the most important takeaways from the study is that patients are continuing to show improvements through use of the twos, and especially being a self-reported wellness measure, this is encouraging overall. These improvements are not associated with clinician-rated relapse risk. That's a tongue twister, suggesting that the twos in ASAM Dimension 5 are likely measuring distinct constructs. So the twos captures patients' internal perception of wellness and progress, whereas ASAM Dimension 5 incorporates additional clinician judgment, external factors. Kind of when we were talking about a lot of the things from the discussions last night, if for those that were there in terms of risk factors and predictive factors and all of those kind of things come into play here. There are also important limitations to consider though. So we had a retrospective design. The use of clinician-rated relapse potential rather than actual relapse outcomes can impact the relationship. And then also the use of a self-reported measure, being the twos, can also introduce bias. These factors may all contribute to why we did not see a stronger relationship. It's also important to consider statistical power. While our sample size was relatively large at 443 participants, the extremely small effect sizes that we saw suggest that even with adequate power, the relationship still would be negligible probably in practice. So the next steps, the twos and ASAM ultimately should be viewed as complementary, not interchangeable tools. Incorporating the perspectives of both clinicians and the clients can provide a more holistic understanding of patient outcomes. So even though patients improved, that improvement does not tell us who is at risk of relapse. So that can help us to guide future research. So examining whether the twos predicts actual relapse outcomes post-discharge, explore how combining patient report and clinician-rated measure may improve predictive models. So instead of looking at how these two predict each other, rather looking at how they work in conjunction with one another is a really great way that we could take this. We discussed as a team as well, also looking at maybe some of the other dimensions of the ASAM, excuse me, that may more closely align with the social determinants of health, where we may see more of a relationship. So clinical implications overall, same sort of idea. The twos is a complementary tool in holistic treatment, but obviously should not be used as a predictive substitute by any means. It can be used to support rather than replace clinical judgment, and there's further research that's needed into how structured social determinant of health measurement tools and clinician-based relapse assessments can be integrated to better predict long-term recovery outcomes. And then we just wanted to acknowledge the amazing team we worked with, our mentors, Michelle Muro. It's worth noting Jean Zhao is at Southwest Behavioral Health and Services and is the reason that we got all of this data, organized all the data for us. So that's a huge thank you there. Dr. Mommertz, who helped guide us and mentor us through this whole process, the rest of the CCART faculty, and obviously our families.
Anyone have any questions or comments or anything?
I have a question.
Yes.
So it sounds like the therapist who rated whether I'm wondering whether their long-term experience working with clients and the fact that they're so used to, I remember when I was on internship, my supervisor, I'm looking at this, oh, this guy's doing so well. in treatment? And he said, oh yeah, they're gonna come back. I was like, really? They're really doing well, this naive intern. And then 6 months later, while I was still in my rotation, they came back. I was like, oh my gosh, how did my professor or supervisor know that? So I'm wondering about that, because of the experience. And so
I absolutely think that's a very interesting point that you bring up, and it's something that we had also talked about too in terms of future directions of making this into like a mixed methods sort of study where we're looking at the perspectives, qualitatively of clinicians and of the actual patients receiving treatment. And I think that would be a very interesting next step to take this, to look at those perspectives and see qualitatively what the perspectives look like in clinical practice.
Oh, yes. So this isn't like in the scope of your study, so I apologize. But I'm curious if the TUS score influences their care. Like, is the score, does that put them in like different categories or like higher risk, or is there anything that changes about their care based on that score?
That's a wonderful question. Thank you very much. And the data that the team used, just so that you know, was from our inpatient population. So danger to self, danger to others, detox services, length of stay, usually a max of 10 days. So the TUS has been instrumental, as well as this research from an agency standpoint. And here's why. We get that baseline feedback from the member related to their health and wellness, 4 domains for the TUS. And in an inpatient setting, we have to be so mindful of social determinants of health. What does their life look like once they leave this secure location? So it gives us that extra insight. Plus, we have found that the therapeutic alliance, when we are letting the member have just share their perspective with us and help us guide services, it makes a huge, profound impact in terms of that member taking accountability as well. So we do the TUS at initial assessment and then also discharge. And how the TUS helps us at discharge is really with readiness to discharge. How this project has helped SBH when the member is discharged from an inpatient setting. We don't just open the door and say good luck. We already are well aware of those social determinants of health, health-related social needs that could put the member at greater risk for relapse. So we do warm handoffs. If they want to go back to their independent apartment or home, great, but we connect them immediately with our outpatient. They already have appointments for the BHMP for their first therapy session before they leave. So this has served as great insight for us as an agency, also to better structure our processes for discharge with those members who have the greatest challenges leaving an inpatient site. Great question. Thank you for asking.
So great presentation, you guys. I'm wondering if you guys have connected with the because I know that you guys were building off last year's work, and I remember last year's presentation and thinking, wow, this is really, interesting and exciting. I'm wondering if you guys have had any communication with that previous group at all to kind of see what you guys like envision the future of the TUS kind of looking like, and what kind of value you feel that it has maybe in how it's going to be utilized in the future, given your findings. And if that's something that you guys have considered as working with that other group too, to kind of brainstorm kind of move forward.
Shane has been a consistent member, right, of both groups. So that has been like kind of the big tie-in. Okay. These students, they disperse far and wide, right?
But it's not really. I mean, Elizabeth Williams, I think, goes in, right? The other group, but she's around, and I think would be open to a conversation.
We have a writing seminar coming up.
That's true.
So
Yeah. Get the groups together.
Yeah. So I guess perhaps they're dispersed, but I know where to find them. So I'm just wondering if you guys have have thought about like a potential, colluding with that group, thinking about, how to move the work forward. Because it's all very valuable and interesting. And I have the same concerns about the ASAM. You expressed them well.
Yeah.
I've used that, I've investigated that metric before and it's somewhat problematic. So.
And for everyone in the room, we have more data than we know what to do. We track our members.
Coming.
No, I mean, birth to 5, 6 to 18, adults, inpatient, community living, residential settings, outpatient settings. We track active members, but we pull our primary research from our discharge members. So beginning, middle, end, and we continue to fine tune. And we get a lot of feedback, not only from members, but as well as our clinicians to how we can adjust the tool to better serve treatment outcomes and to empower our members.
On that order, I would say that working with SBH has proved really seamless. Part of it, I think, is because the other group went first. So we piggyback, the IRB was familiar with us taking data from them. We just updated an old data use agreement. Things went very smoothly for us. They always assign us one partner to communicate with. They make time for us and they meet with us pretty regularly. So if we have ideas in the future, this has proved to be just a seamless partnership. And I want to thank you for that. Yeah, it really went well. Even though the flow of the people that we've communicated with has been different from project to project, right? Although it was SBH, it was different people that we went with, but it has just been seamless.
It's what you dream. It's what you dream.
It is. I told people, I don't know what I did in a previous life to deserve this, but I did something really great because this was, I'm only the mentor, but as a mentor, I sailed through this project. Yeah, it was nice. It was very nice. It was very smooth. Things went well.
Yeah, just if you guys want contact info too from the previous class.
For Elizabeth, I think that'd be a good idea for the writing thing.
I talked to, but Jody is actually in my program.
Cool.
And so I've had like brief conversations with her, and also Shannon sent over their PowerPoint from last year. And so we were able to look at some of the things that they had looked at as well. And just looking at overall like the reliability of the twos as well. So it was nice insight for sure.
Oh, yeah. Great.
Yes.
Well, first of all, great presentation, tremendous work. So we're hoping that our groups are going to take the next step, start to write up some papers about their results and try to publish a manuscript. And as Ramona said, we're going to have a writing retreat where we can bring people together to support them to do that in May. But think about, if you could just address, what would you say, because this is often the section of the paper that you'll have to include, what were some of the strengths, what were some of the limitations? And in terms of limitations, maybe were there some variables or things that you wish you had access to that weren't in the data set that you think might even explain some of your results? But talk about the strengths and limitations.
Definitely some of the limitations overall is just bias that occurs throughout the intake tool, and then also with that, the self-administered questionnaire. Like Dr. Malott was kind of speaking to, that sometimes patients definitely have a lot of insight into their own lives, but they don't know like some of those predictive factors that can, predict relapse risks that maybe they are just unaware of. And of course, clinicians can't predict the future either. But there is that like gap with the insight that can make it hard for the tools to be completely aligned with one another for sure. I don't know if Bree.
In terms of data that we had kind of wished was available, so we narrowed it down from 443. I should have included the number that we had narrowed that down from, because we began with thousands of points of data entry, but the number of complete cases that we had was very limited. But on top of that, so being an archival, retrospective study looking at data that they already had. There were some ideas that we had kind of had going into it of different socioeconomic traits or characteristics for the social determinants of health, like housing status and things like that, that we had kind of wanted to look at. But with the data that we had available, that's kind of why we ended up using race ultimately, because we had the most complete data for that to support that. So I definitely think there's a big area of opportunity, especially if there were to be a novel study introduced to collect more of those social factors that look more at the social determinants of health component of it, because that's what we're really saying here is successful, as opposed to the kind of concerns that we have with the ASAM, clinically.
I will also say that the data that we had regarding race, a majority of the members or the participants were white, and so the ethnic minority group was very small compared to the white population, and so that can also lead to a lot of limitations in just the sample size overall for ethnic minorities. And so because we were looking at race as a moderator and how that impacted, some of that can also play a factor. And then also something I've thought about, or like we've thought about before, is like who the treatment provider is that's filling out the intake, like how many years of experience have they had, maybe even looking at what race they are and what potential bias can come into that, and just different factors in the treatment providers as well, because they are the ones filling out the ASAM. And so whether or not that difference in demographics between the participant and the provider can lead to certain biases or patterns.
We should also note that Tiff is going on to do her dissertation with data that's provided by SPH. So it's, the project will be ongoing in a different venue, in a different line of inquiry, but using a lot of the data and the insight that we took from this project.
Yeah.
Can you hear me?
Yeah.
Okay. Being part of both projects, right? Like I'm kind of contextualizing the twos, although I don't remember the exact questions. But there's parts of it's social determinants of health focused. And there's one question that's about accessing or engaging with treatment services. And why that one stands out is because when we looked at the reliability of the twos across administrations, in the beginning, when you do reliability analysis and like item if removed, what happens? That one had a lot of variability, which makes sense because they hadn't engaged yet. So you have a lot more variability. And then it's stable. So I was wondering about that one, because that's like a more malleable thing in both from the client and program perspective, right? The engagement activity as being predictive of something. Just that one question, that could lead to a little more something we can, learning less tonight about, prevention and community level things. I learned it takes a lot, right? So we're asking people, just how these factors are influencing them, that they really can't control some of them, right? But we can, that one might be something to look at.
So what he's really saying is going smaller,
yeah,
right?
Yeah.
Going smaller, not using the whole score of the twos, but going smaller to one question and starting to investigate a little bit at a time exactly which question might be correlated with, the assessment of relapse by the clinician upon discharge,
We've looked at that in the 4 life domains, at initial assessment, the 4th domain, because the incoming adult, family, or child has not received any services yet. So agency-wide, our leadership was really concerned about inclusivity, no closed doors. And there are people we serve in extremely remote rural areas, no transportation, financial concerns, no vehicles. And there is some upfront paperwork with every agency. The acknowledgement to treat, the consent to treat, there's all just kinds of upfront paperwork. And I know we're in the age of electronics and emailing, but there are a lot of people who don't have that access. So that first domain just literally captures how easy was it for you to get an appointment, the time and date you needed. Did you understand the upfront paperwork? Was someone there to assist you? And then after that initial first capture, that fourth domain is strictly geared to treatment plan, service plan objectives or goals from the member's perspective, because after the initial assessment, the service plan is created. So I agree with you 100%. We've looked at starting from really tracking progress in that fourth domain at first session. That's an ongoing discussion. Let me just put it that way because we have so much current information and data. So I'll just leave it at that. Excellent idea.
I'm just kind of pondering here. So realizing that addiction being a chronic disease, and of course, if there is a return to use, there's so many layers. It affects the family, it affects community. But I'm wondering if other specialties also have predictors of relapse, right? Like, does diabetes have predictors of relapse? Does asthma, does hypertension, if we know that those are also chronic diseases that have very similar relapse rates, hospitalization rates, but we hyper focus on addiction, right? Like, oh, this moral failing, we need to predict when you're going to have a return to use, but we're not doing that, I'm supposing, with other chronic health conditions. So I was just kind of thinking about that. Are there other specialties that are also trying to predict when will this person with asthma be rehospitalized? So
that's because you're thinking of it as a disease. And what we do that with is, of course, recidivism. We do it, because we consider substance use a crime, right? So it's that schizophrenic view of, what is this? Is this health or is this criminality?
Yeah.
And we do, but it's more like the criminal justice, function than it is actually health when we try and predict that.
I have another question, and that is, you looked at clinician scores on the ASAM for relapse. I'm wondering if there's access to, especially if they came back to Southwest, people who did come back, looking at real relapse, as opposed to a prediction of relapse. I'm just curious, Michelle, if that data is available.
We would have, if the member comes back to an inpatient setting, absolutely, we would have that with our current programming. We could certainly also track whatever their needs are moving forward, whether it be medication or substance use treatment, once again, in an outpatient setting or community living or residential. It would just be some cross-referencing with that.
Yeah, interesting too.
We might have it in this data set too, because trimming it down, we looked at just first admission because there are multiple records.
Right,
So
there are multiple records.
Yeah.
Some kind of relational table, right? You can query that you could then count the number of readmissions as an outcome. So.
Lots of
fresh data. We've got boatloads of it.
Oh, by the way, Southwest, from that first one to now, they're really nicely done and clean data sets.
Yeah,
for those of you that appreciate that are community, you know what I mean? Like, I was a counselor and, there's not a ton of missing data. It's all like really well organized and comprehensive.
That speaks to Jing Zhao, who thank you for acknowledging her. Amazing from our IT department.
And just really speaks to your commitment for evidence-based treatment and data at Southwest. And I have to acknowledge Dr. Bob Bohansky, who was a visionary. He was the medical, I'm blanking on his right title, but
chief
psychologist, and really valued data. So he's not with us anymore. He passed away a few years ago, but his vision lives on.
He was my mentor and recruited me in 2006 to work with his department, and we've done many projects over the years. So it was quite, I feel very fortunate to have worked with him for about 16, almost 17 years. So thank you for mentioning that. Very strengths-based in approach with everything we do. There are all kinds of tools out there to tell someone their deficits and their concerns. And we like to flip the script. And as we all discussed last evening with protective factors, certainly identify those risks, but work with each and every member regarding their potential, what they would like to accomplish, and fill in those gaps. So that is how I was trained, and I see the proof every single day with our member outcomes. So thank you for, again, mentioning Dr. Bohansky. He's smiling right now.
He is.
I know.
We're ready to begin our next presentation. So thank you all. I hope you had a good break. And we have Sharita, who is a scholar, CCART scholar, who will be presenting. And Sharita did have a larger team, but one of them had to drop out just a few weeks ago. But Dr. Momartz, who's an integral part of the study, is running a little late. So maybe she'll join us towards the end or maybe not. But Sharita is it. And I'm the add-on, so don't ask me any questions. So, but I'm a cheerleader, so. And you can introduce Dr. Roddy.
Oh, yes. Hi, everyone. Good morning. My name is Dr. Ariel Roddy. I am in the Criminology and Criminal Justice Department here at NAU.
And hello, my name is Sharita LaMarche, and I'm a graduate student in the College of Education, and I'm pursuing a doctoral degree in counseling school psychology.
And I'm Ramona Malata. I think you'll all know me by now. I'm currently the dean for the college, but most of you do know I'm transitioning back to faculty in the combined counseling school psych program, which would be my primary focus, and maybe clinical mental health counseling. She is here, see, because I serve as core. I'm so core for that area. So looking forward to that next fall.
I guess we will go ahead and get started. So, hello, I will be presenting on an evaluation of implementation of harm reduction vending machines within Flagstaff, Arizona, specifically the Guidance Center. Nope. And we have already did a land acknowledgement. And myself. And so I wanted to introduce our community partner, Dr. Babbitt, because she wasn't able to be here today. She's super busy. Dr. Babbitt is a licensed clinical psychologist in Arizona and serves as the chief clinical officer at the Guidance Center in Flagstaff, a role she has held since 2022. She joined the organization in 2020 as a psychologist, providing comprehensive medical and mental health care before advancing into an executive leadership position. Dr. Babbitt earned her PhD in clinical psychology in 2018 and her master's degree in psychology in 2015 from Idaho State University. She completed both her APA accredited internship and postdoctoral fellowship at the University of Utah. Prior to relocating to Northern Arizona, she practiced in Salt Lake City, where she developed extensive experience in community mental health and delivery of evidence-based treatments. She also holds a bachelor's degree from Northern Arizona University, strengthening her longstanding connection to the region she now serves. Additionally, I want to mention that I also work with Michaela Sprague from the Guidance Center, who is a lead case manager in the adult side. This person is worked with the company for about 3 years and been a part of the SOR4 grant for about 1.5 years now. And as we've already talked about, my advisors and mentors, who wasn't mentioned was Dr. Katie Momartz, who is the executive director of Postpartum Support International in the Arizona chapter. So the Guidance Center is a not-for-profit community mental health center with locations serving Flagstaff and the greater Northern Arizona community since 1969. They have a full continuum of inpatient and outpatient behavioral healthcare services for all age groups, such as adult mental health services, substance use treatment, inpatient and outpatient psychiatric services, crisis services, as well as child and family services. So I'm going to talk a little bit about the evolution of harm reduction vending machines, and hopefully this gives a little context of how we have gotten to America, I guess you could say. So in 1987, Denmark was the first to introduce and implement harm reduction vending machines. Their machines distributed naloxone and sterile syringes to reduce HIV and hepatitis transmission, establishing anonymity with 24-hour care, which was a core principle in harm reduction principles. In 2000, Germany initiated sterile syringe exchange, overdose prevention, and vending machine distribution into public health systems, becoming a global leader in harm reduction infrastructure. In a survey, 77% of the participants reported that the vending machines were regularly used about 4 times per week. Between 2000 and 2010, Europe became embedded in their culture as far as harm reduction practices and vending machines. This strengthened evidence emerged to reduce in overdose deaths and infectious disease transmission. Vending machines increasingly distributed naloxone, testing supplies, and hygiene items. In 2009, Puerto Rico implemented the first harm reduction vending machines. And then in 2017, it was brought over to the mainlands, and Nevada tested it in 2017. And so today, 2021, Arizona Revised Statute 133415 F2D, it excluded drug paraphernalia, meaning narcotic drug testing products that were used to determine whether controlled substances had fentanyl or fentanyl analogy, allowed community members and facilities to possess and distribute fentanyl test strips, was no longer considered a crime or illegal. This allowed healthcare organizations to promote safe substance use practices. Additionally, the Chief Medical Officer of Public Health at the Arizona Department of Health Services authorized prescribers to prescribe and dispense naloxone to individuals at risk of opioid overdose and to family members, which made it possible for the public distribution of naloxone in public locations. So I'm sure you've now been able to see different dispensaries throughout the community. In 2025, the Guidance Center became a recipient of the State Opioid Response 4 grant. The grant provided funding for treatment services, which allowed 24/7 opioid treatment programs for intake, assessment, and ongoing psychosocial assessments. It also funded medication for opioid use disorders, or MOUDs, and methadone and Suboxone in clinics as well as correctional facilities. Mobile units allowed mobile MOUD units to reach rural areas where transportation was a barrier. Prevention and harm reduction funding, which made it used to purchase and distribute naloxone and fentanyl test strips. Additionally, recovery supplies in which providers were offered transitional and supportive housing, vocational training, and life skills training. Ongoing and navigation funding, which supported peer navigators, street-based outreach teams, and reach-in programs in emergency rooms to connect individuals to treatment. Next, it was training and consultation, where facilities were able to use the funding to train staff on trauma-informed care and MOUD referrals. Harm reduction vending machines has become an effective effort to continue to support individuals who use substances while accessing to safer and healthier choices. The Guidance Center was provided 2 harm reduction vending machines and monthly supplies to individuals at risk within the community. Harm reduction vending machines are anonymously allowing individuals to access materials such as naloxone, hygiene care, fentanyl test strips, and anything the community deems necessary to support the community members. There are different vending machines around our community. If you notice, the Flagstaff Medical Center Emergency Department, as well as Coconino County's Health and Human Services. Each location has different supplies to meet the community's needs. The Guidance Center provides the community with socks, hygiene products, women's hygiene kits, tote bags, blankets, Narcan, fentanyl test strips, CPR mask, and face masks. These supplies are available to the community, the staff, and anyone who is in need, regardless if they live or work within Coconino County. In previous studies, community members have been concerned about increased drug use and syringe litter, and this may have been a determining factor of why the Guidance Center chose those specific supplies. Thus far, through the literature, Nevada seems to be the most widely accessible, modern, financially functional system, as they have automated the vending machine systems where they have a passcode or a swipe card that can be used since 2017. The state is able to monitor the supplies that different ones are using and the quantity at various locations. The literature review suggests other states such as Rhode Island, Maryland, New Jersey, who are in the early stages of implementation or piloting the initiative. So far, 33 states and 2 indigenous communities in the Midwest have had an opportunity to participate in 24/7 access to free naloxone, fentanyl test strips, and other health supplies. The Community Guidance Center decided to implement the vending machines on their site to maximize accessibility for their community members, realizing the needs of their community members. Russell et al. Believed it was important to establish a good feedback loop between the organization, the participants, and the community. This study was implemented to support the feedback loop, to gain more information on the perception of the community and for the staff members and anyone who visits the Guidance Center campus. In the area of usability and privacy, inventory and community needs, and the impact on harm reduction behavior. The research questions focus on the perception of the community members from their point of view and how the staff perceive the vending machines on their campus. The questions that we focused on was what are the experiences and challenges affecting engagement with the vending machines, such as privacy, stigma, and usability. Next, to what extent does the current supplies align with the individual's needs and what additional needs exist? And lastly, what is the perceived impact of vending machine access on harm reduction practices? So I'm going to go into the methods section. Initially, the study design was a mixed method research design. Through the literature, there was notice that there was quantitative literature studies, and then there was qualitative studies that were conducted. But there had only been one mixed method that incorporated both aspects. They noted 13 quantitative and 10 qualitatives within this scoping literature review. And so we went really broad when we considered this. We created a quantitative survey for the community members as well as for the staff members. And then we also created a semi-structured interview with questions to provide to the participants. It started off as a focus group and then it just got smaller and smaller into individual interviews. But the information that we will be discussing today will be the quantitative survey due to the time constraints of this study itself. Okay, during the recruitment process, the thought was that we had created a flyer. We went out to the different support groups that the Guidance Center had held. Some of the participants were on Zoom, some were in person, and we wanted them to be able to talk to their friends and to different staff members, go to the vending machines, anything that might be able to kind of encourage more participation. Within the study, we had monetary incentives for those who completed the survey, and then there was an additional monetary incentive for those who participated in the semi-structured interview. We were interested in the voices of the community, regardless if they were staff members or if they were part of the TGC program. So because there is an outside and an indoor location, it was open to anyone. The only criteria was that they kind of reside or work in Coconino County, and that was just more or less so that we would kind of know within this area because it's in Flagstaff, and that the person was 18 years or older. We were not concerned about the gender, race, or ethnicity. We wanted to get as many people as we could. We were very conscientious of the population within Flagstaff. At the time of the research project's closure, we had 7 participants complete the survey, 4 employees and 3 community members. We did have 2 people who were interested in completing the semi-structured interview, but at the time of putting this all together, they had not responded back to the invitation. So these are some of the questions that were incorporated into the member survey items, such as, do you know how to test your substances for contaminants? Do you test your substances you use before taking them to make sure that, there isn't any fentanyl in there? Do you know how to operate the vending machines? How satisfied are you with the variety of items available? Do you have a Narcan or naloxone kit present while you're using? And how often do you find the vending machines empty or low on stock? The staff survey items were a little different. Initially, I think we kind of did a combination of both, but then we realized that maybe the staff members need different ones. And so the questions were, how confident do you feel explaining the purpose and function of the vending machines to clients? Have you ever recommended or directed a client or community member to use the machines? How clear is the process for reporting low stock or maintenance issues in the vending machines? Do you know who to contact if you notice vending machines are low on supplies? And if you could change one thing about the location, signage, or content of the machines, what would it be? So next, I'm going to go into the results. We were exploring members' perceived experience and challenges that affected engagement with the vending machines. What we noticed is all members knew how to access the vending machines. They felt comfortable using them and felt safe from stigma and judgment when using the vending machines. We noticed there were a variety of answers about which ones they might use. One person said they use the inside vending machines. Another person said they use the vending machines at the Health and Human Services location. And one person had stated that they had never used the vending machines. All members reported the vending machine locations provided enough privacy. And interesting, one person reported feeling watched while accessing the vending machines, while the other 2 never felt watched while at the vending machines. Then, as we explored the perceived experiences and challenges that affected staff engagement with the vending machines, all staff members reported some degree of confidence in the purpose and the function of the vending machines. All staff believed that the vending machines were a valuable resource to the community members. However, only half of the respondents admitted to directing community members to the vending machines. Half of the staff said that they felt that the location was private or semi-private and very visible, while the other half said that it was semi-private. So then we were looking at the members' use of the vending machines and what supplies they were really gathering. So the members who responded seemed to be pretty neutral about their satisfaction in the variety of items. However, 2 members reported the vending machines were rarely empty, while one person said that they were sometimes empty. This is a graph of the items that the participants said that they had obtained from the vending machine. I thought it was worth noting that none of the members reported experiencing an accidental opioid, such as heroin or fentanyl, or a stimulant such as meth or cocaine overdose in the past 6 months. So when considering the staff's perception of supply inventory, 3 out of the 4 staff members perceived the vending machines supplies to be fully stocked with resources, and 1 person felt that the machines were occasionally low on stock. Then 3 out of the 4 staff members knew who to contact when the vending machines were low on supplies. All members were neutral in their understanding of the process for reporting low inventory. Okay. So what is the perceived impact of the vending machines on harm reduction practices? Thoughts from the members on the impact of this behavior can be seen in the graphs below or around. The first bar graph, 2 members reported having known how to test their substances, while 1 person stated they were unfamiliar with how to test their substances for contaminants such as fentanyl. In the second bar graph, only 1 person reported they tested their drugs before using them. 2 people reported not testing their drugs before using them. In the third bar graph, it represents whether members had a naloxone or Narcan kit during their substance use. 2 people reported Narcan or naloxone with them when they got high, while 1 person reported not carrying Narcan or naloxone. The next set of thoughts comes from the staff members regarding their perceived impact on harm reduction behaviors. 3 staff members stated that they had never accessed the vending machines, while 1 person stated that they had used it to gain a tote bag for a community member. Staff members did not provide a response if they had used a naloxone or Narcan kit obtained from one of the vending machines on the TGC campus. So next, the identified comments regarding the research questions focus on usability and privacy concerns. All staff members reported being moderately and extremely confident in explaining the machines to clients. However, the process for reporting malfunctions was unclear. This indicates that while the purpose of the machines was understood, the logistical maintenance procedures could have been better communicated to staff. Supply diversification. 1 member reported having a wide variety of items, as you saw before. This confirms that the vending machines are a serious source of social determinants of health, providing dignity and basic survival resources alongside medical tools. While most respondents found the machines rarely or never empty, 1 member noted that it was sometimes empty. This highlights the need for consistent restocking schedules as word of mouth about the machines spread to the wider community and they become more increasingly accessible. The impact on harm reduction behavior. Half of the staff had already directly recommended a client to the machines. This referral behavior is essential in building trust among a population that may be hesitant to use new resources without verbal endorsement from a known provider. While drug testing was reported as never for 2 members, 1 person reported testing occasionally, highlighting that the presence of the machines provided a reoccurring opportunity for behavioral shifts in drug checking habits. When we just think about the strengths of it, a mixed method design, which allows quantitative and qualitative perspective, as well as further details about the utilization of the vending machines and how to improve the accessibility of resources for the community members is very important. The fact that it was a community-based research is also an advantage for the Guidance Center because it allows for them to have researchers, community members, and the facility have a big discussion about the openness of their perspectives and the process of supporting change within their community. When considering the limitations, I initially thought about the vending machine malfunction. In July 2025, I was unsure about the vending machines, the Guidance Center, and all of the things they offered. So I took a visit. I went down there and I found the vending machine and I tried to use it and nothing happened. And so I wasn't sure if I was like a user error or what happened. Later on, once we got approved for the research project, I ended up getting a supervised tour by Michaela, and she was able to show me around the campus and show me all the vending machines and how to use them. What we noticed was one of the vending machines was malfunction. It was the outside location. That's the location that provides a further reach to clients who may be concerned about privacy or their desire to have 24-hour access. Other studies, such as Stark et al. And Russell et al., reported that machine failures or power outages in older machines resulted in individuals reverting back to high-risk needle sharing. In my case, it may have hindered others in their ability to come back and get supplies. I noticed there was no one who directed me to a different machine. There wasn't there wasn't a sign or anything like that. So I could see how that might affect the larger community. Additionally, due to the initial nature of the pilot study, a sample size of 4 employees and 3 community members was not enough information possibly to generalize to the greater community. I believe that the limited time to coordinate in-person recruitment, as well as visiting support groups at the Guidance Center and making individuals aware of the research study that was occurring on the premises was a limitation. Additionally, I've later found out that to put a flyer on the community board, you have to have it approved by the board members. So when considering recommendations, it would be increasing awareness, prioritizing community awareness by increasing community activities centralized on the vending machines. Also, it might be advantageous to update the website or online presence, as Google only found 2 locations within the community. Enhancing signage. Implementing clear, large print signage explicitly stating free resources, no payment required, to remove immediate financial hesitations, as well as instructions on how to use the vending machine. Instructions on how to use the items in the vending machine, such as the fentanyl test strips, and labeling materials in the vending machine so people know what they're looking at and grabbing. Also, refining the maintenance protocol. Providing staff with a simple, standardized procedure, such as a QR code to report if the machine is malfunctioning or low on stock. Inventory data is collected monthly at this time, but if inventory was collected weekly or more frequently, there may be an opportunity to determine which items were used more frequently and switch out items that appeal to the community at large, such as condoms or pregnancy tests. If I had an opportunity to do this again, I would definitely try it. And to extend, I would love to look at all of the vending machines in Flagstaff, Arizona, and see how they differ and what are their strengths. This project was made possible through the generous partnership with the Guidance Center and the clinical director, Dr. Stephanie Babbitt. I have a heartfelt thank you to Michaela Spriggs, who was an unsung vital part in this effort, as they were able to, one, connect me to the community members. They helped me set up all the support groups and really just helping me to understand the Guidance Center better. Also, I'm deeply grateful for my mentors, Dr. Roddy, Dr. Momart, Dr. Malat, and their expertise, patience, and steadfast engagement throughout this research process. Are there any questions or thoughts or concerns?
Yeah, I do. So first of all, I know, Sharita, you had a lot of challenges with this project. And so shout out to you for finishing it out. This is very important work that you're doing. I know it's primarily here in Flagstaff, but do you know if there are any in Phoenix, or if it's just connected to the Guidance Center? And if there are in Phoenix, how do we find them? Like, how do we hear about this super important work that you're doing? Yeah.
So my understanding, since the SOR4 grant came out, a lot of different mental health and medical facilities have started incorporating it into their systems. And so, yes, they are in Phoenix. They are also down in Tucson. And as I tell people that I was doing the study, someone was down in Winslow and they took a picture and sent it to me of a naloxone distribution. So, I mean, they're definitely out there. That particular one was in a library, which was shocking to see. But we know that a lot of different community members access the library, regardless if they're unhoused or, you know, they're there with their children or whatever. So it is one of the pillars within the community. And you can do a Google search. That's really what I did. And I found out like a lot of places had like news reports of how they were being implemented or brought into the community. Yes.
Do you have any access to the usage data for the vending machines? How often are they being used? What sort of supplies is being collected?
So at this moment, they're collecting data monthly. And so I did have access to the usage data, but it was more or less making sure that it was full. So they didn't really like count it as how much inventory was being used. And that's why I thought it would be nice to have a weekly. So then you could say, oh, there were four pairs of socks taken on, and which vending machines it was being used out of.
Those machines should record like the time of use and what was dispensed, right? It feels like
that would be
they would record that somewhere. That's a database somewhere. Even though it's collected monthly, I think it would be recorded instantly. But you saw the picture of the vending machines, they're electronic.
Well, okay, so there's different, I think a vending machine has evolved thus, you know, like we have the electronic ones where you can use your little swipe card or your credit card to access different things about it. And then there's the manual ones where.
Were these manual?
Yes, I would say they were more on the manual side. And so I don't know how much data they would be accessing. There is a keypad.
Punch, yeah, would record. It feels like, so it feels like they probably collected monthly, but I bet that's recorded instantaneously with the time and the date and the item that was dispensed. You wouldn't know who.
I would love that.
But yeah, I imagine.
I would love to look more into that. And if that is something, that's something for me to consider in the future when I'm doing research.
Yeah, I'd be interested.
Yeah. Oh, okay, this way, that way.
Okay, and I was thinking too, to increase participation, because isn't that the hardest part of the study, right? Is to get folks to participate, even like QR codes on labels that's on every single item. So that way when they get their item, they see it and it's like, oh, maybe I can do this. Because I think that's such valuable data. Like, did you know, like there's test strips, right? Because they may be getting socks and not even thinking like, oh, my friend might need this test strip. So yeah, such a cool study. That whoever, if you continue with it or someone else does, just to see, because it is such a newer concept in our society. Yeah.
I didn't even consider about the QR code on each individual item. That's actually really smart.
You know, I just ran a Google search on my phone, Google Maps. It came up. So, not every location, but some of them came up. Google Maps. So it's fun.
And you?
Yeah, I was wondering if you could maybe reflect a little bit more around the recruitment issues that you encountered, which is, I think we're all familiar with it. Recruitment is one of the hardest things of research, and I think it's a difficult thing. So I was wondering if you could say a little bit more about what you learned and also how you think, what you would do differently, how you think you could have got more participants. I wondered if you had just a few more thoughts, because it's such an important piece of getting the data, right? Yes, that working, we're sort of, you know, you have that limitation.
Some of the barriers that I encountered were the time constraints. So by the time we were approved for, and I keep saying we, but now it's just me, that was also a barrier. But the time constraints, so we probably had 30 days to collect, which I don't think that allowed enough time for participants to fully be aware of the study and to know or feel comfortable enough to say, do I want to do this or not want to do this? Initially, there were the QR codes on the vending machines, and then we had passed out the flyers to each of the case managers who were working with different clients. So the thought was, is when they came in for their intake or their follow-up or whatever, the the case manager could be like, oh, would you be interested in taking this survey? After 2 weeks, I realized that I had not received a lot of participation. And so then I spoke with Michaela, and we had coordinated that I would be able to go into different support groups. And so I'm only one person, so I was only able to go to a couple of different support groups and kind of talk to them about the research and being able to provide them with the QR code. Additionally, the support groups, there were members on Zoom, as I had mentioned, as well as in person. And so technology is sometimes not our friend. And so walking the different clients that were on Zoom through the process and putting the code into the Zoom and all that other stuff. So those were some of the things that I think were.
Are you planning to collect some more?
I would love to. I've been kind of tossing it up if I wanted this to be a dissertation topic, or if just continuing with the manuscript and just getting a wider community. Hi, Dr. Babbitt.
I was just curious, just as a clarification question about your participants in terms of like, if you knew that all of them came from vending machines from the guidance center, just because I think the emergency department vending machine is a really interesting component here, because thinking about, physicians, mid-levels, allied health professionals from a medical and clinical decision-making, position, I think that those vending machines could play a very interesting role in that particular setting. So I was just curious for clarification on if like your participants were just coming from the emergency room setting or not. Just the guidance center, or if any of them came from that emergency room location.
That was a survey item, and one person said they'd used the ones at the Health and Human Services department. No one mentioned the emergency department. So I guess one said inside, so that would have been the guidance center campus. It's me.
I'm very excited, but is there like a central department that stocks all of them, or are each location stocked by the facility?
Are you saying like the Flagstaff Medical and then Health and Human Services and then the Guidance Center?
Yeah, are they all stocked by the same organization?
I'm not familiar with Flagstaff Medical Center or the Health and Human Services. At the Guidance Center, Michaela is the one who stocks the inside and outside vending machines and keeps track of the stock and inventory.
Our staff at FMC does the.
Okay, so it is.
And that's why I think it's so interesting to kind of determine like what materials are they using, and the fact that, the guidance center has different things than what the emergency department has. So I think that's interesting.
All right, one more question for you. Do you have any thoughts on how, on improving the supplies that is in the vending machines? Like what our community actually needs? Because at FMC, we're very limited. We don't have the same stock. Like all we have is fentanyl, test strips, and Narcan in the emergency department. But I'd be curious if you have thoughts on how to improve what those vending machines supply.
Well, I mean, there's a wide variety of things that can be implemented or introduced into the vending machines through the research. Like some were saying that they had snacks and wound care kits and pregnancy and condom. You're thinking of safer practices in that manner. But you wouldn't really know until you've actually like looked at the inventory itself and what the community needs as far as that goes. Because I also consider like, how does that affect those who may be using different types of substances?
Sharita, at the guidance center, which supplies were used more often? I think don't you have a slide up there?
The participant mentioned using pretty much a variety of everything. So it was pretty even across like the fentanyl test strips and so what was mostly used was the full day bus pass. That's what was mostly used. And so due to that the high obtainment, that ended up being kept by the case managers, and then it had to be requested for the use because they realized people were possibly maybe keeping 3 or 4 at a time. And the initial purpose was so that people would have opportunities to go to medical appointment, housing, locations, those type of things.
Sorry if you said this, but does it cost money if you have to have a card or cash to put in, or is some of the stuff free or?
So on the Guidance Center campus, and I believe throughout the community, they're free. Anyone can walk up, and that's why I tried to do that. But I didn't know what I was doing. And there were no instructions to help me through the process. And so I think being able to have signage that says that it's free, I think that that would encourage more participants or encourage more community members to give it a try.
You went to do it. I mean, isn't it just punch a button? Isn't it just punch a button?
I said, I'm a doctoral student. Why can't I use a vending machine? Honestly, I'm like, I should know how to do this. I bought snacks before. So yeah, what was wrong with it? We found out later that there's a power shortage because it was being shared, like the wall was being shared, I guess, on the other side of something else, which was using high electrovolts. I don't know much about electricity, but, and it was causing a shortage on the vending machine.
It wasn't you.
Right.
Right. Oh, that's just what I wondered.
Right. It wasn't me. But I just think about the fact that that's the outside one. So that's the one that the community members are being the access 24/7 with privacy. So at 11 o'clock at night, and I think I went 4th of July weekend on purpose. And, you know, you're having a good time. There was no way to access those resources. And I thought that was important. And then through the survey, they are fixing it. So it's okay. They will be able to have access to the materials.
So sort of through your lit review or search, how are they received in Europe? So when we're having all these barriers and trouble, are they just welcome, widely used? Is it totally different? Yeah.
Europe is so forward thinking.
Right.
So 1961, the United States felt that it was super important to put a handle on drugs. So they created, you know, within the United Nations that, hey, we need to know who's making them, who's supplying them. We need to have more stringent rules on this. We need to criminalize it. That's going to stop it. We all know criminalizing it did not stop it. Europe took a different perspective or a different route. And so what they did is they opened up consumption use buildings in a sense so that anyone could come in and use in a safer manner. They also started allowing sterile syringe use, you know, free needles, clean needles, those type of things. The US has not responded in the same direction. I think Canada has been piloting some programs as far as consumption use sites. We haven't gotten there just due to the different criminalization laws. So a lot of facilities are afraid to open them. One, becoming a target, two, finding grants to support it, and staff members. They're fully embedded in Europe and they are encouraged throughout. Are there any other questions? Thank you.
You can direct your attention to our evaluation materials, and it's going to be a couple parts. So this first QR code is for those agencies that were involved with our scholars this time around in this project, right? So it's the only people.
Southwest, the Guidance Center, and Customer.
So what this one is, this survey, we'd like to get your input about what the experience was like, maybe how in some ways it transformed your agency, what kind of, you know, it's a scaling questionnaire to get your feedback, and we track all this. For the scholars, I know you have focus groups that have had already.
No.
Okay, you'll have a focus group, but Amy will be sending emails for those scholars to complete some more surveys. And it's really, really, really important. Did I say really? So it does a few things. One, it just lets us know lots of different factors, your experience with mentorship, with the community research project, with your confidence in research. And that survey actually shows the greatest gains. So overall, the scholars gain more confidence, right, in doing clinical research. So it's really, really helpful for us to get that information. As we've learned about sample sizes, really important for us to do. And it does another thing. So we take this information. It doesn't just go out there into Qualtrics land. We take it and we bring it back to our executive committee. We look for themes. We take your input and we try to make the program better or address anything that might be problematic. So we've made some real changes to the curriculum based upon the feedback, right? So we take this feedback and we made like major structural changes. It also informed our reapplication for the grant. So it is useful and meaningful. And we'll remind you again later on, and it's important to fill this out throughout the day. The other thing that came from this is a writing retreat. That might have come from a focus group or combination of data, you know, where we have this writing retreat we like to offer to come in and get all the good work you do into a publication somewhere. So that's all I have. I know we have lunch coming up, right? Okay. 5 minutes. So thank you. Just take a look at it, start it. It should take 10 minutes. It's not really that long. So thanks.
All right, everyone. I hope everyone enjoyed lunch. We were just talking about how the food at this conference has been really good. So thanks so much for the great orders, you guys. So as I've introduced myself before, my name is Ariel Roddy, and I'm here to provide an introduction for a man that needs no introduction, Lee Yeva. So he's a member of the Hopi tribe. He is also the CEO of Scottsdale Recovery Center, the owner of HNIC LLC, the founder of Restoration Health and Healing, and with 21 years of experience in behavioral health and addiction treatment, Yeva is known for leading clinical acumen with business insight, driving innovative solutions to address the evolving trends in therapeutic interventions and service delivery. Named one of Arizona's most influential minority business leaders by AZ Big Media and featured in AZ Business Leaders magazine, Yeva is a sought-after national speaker who focuses on empowering minority and underserved communities. His leadership is distinctive, characterized by a meticulous approach to achieving organizational goals, and he leads with precision and purpose. Navigating complexities of the industry with confidence, Yeva makes data-driven decisions that not only elevate the standard of care, but also ensure sustainable growth and success. I'll add a personal touch to this. Lee has been, ever since I've arrived kind of in Arizona, which has not been particularly long, I've seen Lee's kind of commitment and transformation of the spaces that he enters. So I'm really excited to hear this talk. I've heard him speak numerous times, and I'm just grateful that he's here. So without further ado, here's Lee Yeva.
All right, can everybody hear me?
Mm-hmm.
Good? All right, cool. I love the introduction. That's all AI. Yeah. All right, before I start, I just wanted to say, in my language, that means I'm very glad, I'm very appreciative, I'm very grateful, I'm very happy that we all made it, right? And so in this opening opportunity for me to establish the foundation of the conversation that we'll have today is really, I want, and I always reinforce this consistently everywhere I go, I want you guys to imagine and to understand, acknowledge, and remember that you're an endangered species. There's only one like you in the entire world. Can you imagine that? That you are an endangered species and that there's only one, just one, out of the entirety of the entire world. There's only one Nancy. There's only one Ariel. There's only one Vincent. There's only one in the entire world. And if you truly understand that, you might treat yourself a little bit differently, right? You might honor your presence in this world. And in addition to that, I also want to just reinforce an idea and a thought that I have, that when you come into this world, when you're received into this world, everybody gathers around and they await your arrival. And when you come into the world, the doctor says he or she is crowning, and you're crowned king and queen before you even realize that you're a royalty, right? And I love that idea because in that moment, when you're received into the world, people cater to your every need. You have no wants. People shower you with love and security and just a compassion that it exudes from everybody who comes into your presence. And so when I think about all those things, I think about the industry that you guys are going into and the immense responsibility that you guys have. In fact, when I was outside, I was looking at something and I saw this. And I thought to myself, this is how badly that you are needed, right? And the distinct way in which you provide that service is going to determine longevity, sustainability, maintenance, and a true understanding of the responsibility that you have to the world. And so when I was preparing for this presentation, I was really thinking about the gravity of what you are going to be responsible for, or that you're already responsible for. And my evolution into the industry isn't one, I didn't follow your lead. I'm 21 years clean. Prior to this, I was a homeless alcoholic and drug addict living off the streets of Torrance, California. Piss in my pants, vomit on my shirt, 40-ounce OD, high gravity for anybody that knows malt liquor, cocaine, methamphetamine, the whole nine. And I stayed out on the street for 2 years, and that was by intent. I chose to live on the street because I got to a point in life to where I had absolutely no desire to live whatsoever. I was done. And I was so broken that there was a day when I was at work, and prior to that, I was very successful. I was a regional director for the Big Five Corporation, and I managed all of Southern California. Had a home in Ranchos Palos Verdes, 5 bedrooms, 3-car garage, 3 cars in it, suits for days, and a trophy wife. And I looked at that and I really thought in my mind, coming from an indigenous background, coming from the upbringing that I did, I have gone through everything that a human being can go through. Sexual abuse from 5 to 7, homicide, suicide, alcoholism, drug addiction, overdose, incarceration. I mean, you name it, I've gone through all of it. And so by the time I got to this position in life, I really thought that if I pursue these objectives and I secure them, it will create an opportunity for wellness and happiness. And I'll finally be in a position to where I can be grateful for life. And I got there, and that's not what happened. And so one day I went out and I ended up on the street, and I just stayed there. And the reason why was because that night I fell into a bunch of oleanders upside down, and I was so intoxicated that I couldn't get back up. So I just stayed there. And the next morning, people walked past me without any regard. And I got up and I looked around at everybody, and it was pure silence. Nobody cared that I was there. Nobody acknowledged me. People stepped over me. And I remember thinking to myself, this is great. Nobody sees me. Nobody cares. And they're treating me the way that I feel about myself, without regard. No reserve in regards to capacity to love or an ability to exude compassion. And so by choice, I stayed out there. And I know it was 2 years because I missed 2 Super Bowls. I don't know who won. And I always measure that time frame because from 1 year over the other, I remember just feeling in this place to where people used to flick nickels, pennies, and dimes at me. And prior to that, like I said, I was very successful. So I had a savings account. I never panhandled. I never asked for money. But I would sit outside of a liquor store with a fifth of Jack Daniels, and I would be drinking, and they would flick nickels, pennies, and dimes at me. And change has a life of its own. And so what it would do is that I would watch that coin roll, and it would come into a little circle, and then it would settle. And I would look at that penny, and I would think to myself, me and that penny are equitous, because nobody will take the time to pick it up. Nobody recognizes its value, and nobody sees its worth. And so me and the penny had a very unique relationship. And throughout that entire experience, I got to a position to where towards the tail end of 2 years, I really thought to myself, I'm done. By this point, I'm throwing up blood every day. I'm yellowish gray. I'm legit near death. And I wanted to just put a stamp on it, right? I wanted it to be done. And so I went to Vaughn's and Ralph's, and I had relinquished the responsibility of having a driver's license by this point. So I had 3 cars, none of them I could drive. And I want to reinforce that as well. There's this terminology that goes around in this industry where people say, I lost my car, I lost my job, I lost my wife, I lost my family. Nobody loses anything in this. It's a decision that we choose to make. Granted, for the first time you go into a treatment facility, you acquire knowledge and information on how to acquire a position of wellness that may give you some insight. And maybe you can say, I wasn't aware that this was going to be the end result. But once you have that initial experience, there is no victims in this. And so when I decided I got a room, a motel, and I prepaid for 30 days in advance. And I was fully intent on using and drinking myself to death in this room. And I came pretty close. And on the 29th night, I woke up, and usually 2 o'clock in the morning, my body just needed something, whether it was another hit, another line, another whatever. And I got up and I was having DTs. I was shaking really bad. And I looked at the clock and it said 2 o'clock in the morning. It's like 2:13. And I thought to myself, there's 4 hours until the nearest liquor store opens up. And I thought, how am I going to navigate the next 4 hours? And so in this room, it was filled with alcohol, empty alcohol bottles, everything from 40 ounces, beer cans, bottles of Jack Daniels. And so what I decided to do is that I was going to go through the alcohol settles at the bottom after a while. And I thought I'm going to drink all this alcohol until all the bottles are on this side of the room. And knowing full well that I spit in them, there was roaches in there, from smoking joints or blunts and cigarette butts. I drank them anyway until they were all on this side of the room. And when I did that, I felt some relief. I was like, okay, good. I think I can navigate the next 2 hours. And then that 2 hour time period came to pass. And in between there, I was still thinking, like, what am I going to do? Because I don't have any more money. I exhausted all of the finance. I think I had like $400 left to my name. And I decided in that moment, I was going to go take a shower. And I thought to myself, I couldn't even remember the last time I touched water. And I do know that prior to that, I think I tried to eat one time and I went to Jack in the Box and I could only eat like a little piece of the taco. And I just couldn't eat. By that point, all my entire diet consisted of drugs and alcohol. That was it. And so when I went into the shower, it was the most uncomfortable feeling I've ever had. I hadn't touched water for so long that the water touching my body just felt like the sexual abuse all over again. Like it was so foreign to me. That's how long I hadn't touched water for. And on occasion, I would take a bath inside the gas station bathroom with the pink powder soap. And when they were dry, it'd be super itchy. But on this occasion, I remember I got out. I barely washed my hands and my face and I got out. And then I looked at myself in the mirror just prior to that. And I remember looking at myself and I just started crying. And I was like, what happened to you? You used to be so ambitious, so motivated, so, you had a desire and a lust to live. And somehow or other throughout the course of all of these situations and scenarios and environmental influence and all kinds of things, I found myself in that position. And all I did is the simplest prayer I've ever said in my life. I just went to the edge of this bed and I said, please, God, help me. That's it. I'm not too sure if you guys have this experience, but if you go through life the way that I did and those cell doors shut and you think to yourself, please, God, if you get me out of this, I promise I won't never do it again. You're real elaborate with your prayers. This time I just went to the edge of that bed and I said, please, God, help me. That's it. And I don't know what happened after that, but after that was just a series of events that led me to where I am present day. And I don't want to get too much into the war stories, but I want to get into the evolution. And when that happened, I always remember I got a phone card when I went to the liquor store because I did need alcohol just to make it. And I got a phone card and I called back home and nobody's number who I could remember answered. Nobody. I went through the entire Rolodex in my head and nobody answered the phone until the last person that I called was my Uncle Stan. And his wife actually picked up the phone and I told her what was going on. And she goes, let me get your uncle on the line. So he gets on the phone and I'm talking to him. At the end of the little conversation, he said, don't worry, son, we're going to get you home. And he never called me son before. He's my dad's brother and we're cool, but we're not close. But when he said that to me, it was like, man. And I had been searching my entire life for a father because I grew up without a father, without a father figure or a role model that would really fill the void that I had in my life to keep me safe and to keep me secure and to ensure that nobody would touch me or abuse me the way that I was, right? And so next thing you know, I'm heading to the airport in Long Beach. And when I get to Long Beach, the first miracle happens. When I get there, all I have is a little Walmart bag of underwear. That's all I got left to my name, my ID, social security card, and $400. I go up to the ticket counter and I say, I need the next flight to Phoenix. And she looks at me and she's, doing her thing. And then she says, I'm sorry, but the last flight to Phoenix is boarding right now. You're not going to be able to make this flight, but I'll book you for the next one, the first one tomorrow morning. And immediately I started thinking, where's the nearest liquor store? Where's the nearest dope man that I know? And before I could get too far into that thought, this woman with bright red curly hair pops through the double doors where they take your luggage. And she pointed right at me and she goes, "Are you going to Phoenix?" And I said, "Yes, I am." And keep in mind, Long Beach is an international airport. I could have been going anywhere, and she was not in close proximity to this conversation at all. And yet she came through and she pointed right at me and she said, "Are you going to Phoenix?" And I said, "Yes, I am." And she goes, "If you can pay for your ticket and run like hell to the boarding gate, you can make this flight." And so that's what I did. And I got onto the plane. And I remember it was really windy that day. And it was raining. And we got up so far, and the captain came onto the intercom and said, "Before you reach your destination, you will experience some turbulence." And I thought, no shit. And I landed here in Phoenix, in Arizona. On the short flight, I went to detox, and I met a gentleman there who just kept coming to me and talking to me about this military-based program. I had been in the Marine Corps prior to that, and he kept telling me about this program. And I had my mind made up. I'm going to go to Native American Connections. I know people there. I've been through that program before, blah, blah, blah. But before I left California, I made another promise, and I said, "If you help me, I'll follow whoever you put in my path. I'll follow them. I promise. Just please help me." And so this gentleman, his name is Jerry, he kept coming to me, and finally I just told him no. I told him I had a plan. I knew where I was going. I knew what I was doing. And finally, I was about ready to be discharged. My vitals were stable and they were about to release me. And he came up one last time, and I remembered my prayer. And I told him, I remember what I had told my creator. And he goes, "I just came back one last time. I'm going to just, give it another shot. Have you given any thought to this program?" And I said, "I'll go." And he lit up and he said, "You will?" And I said, "Yes, I'll go." And so we got into a van. It's probably like about 10 o'clock at night. I'm driving out way far into the West Valley. And when I get there, I meet my mentor and my mother. These two become my parental figures in life. I met Lee and Cindy Humes. And I remember when I walked into the lobby, I'm standing there, I have my little bag of underwear, and he comes up to me and he goes, "What's your name?" And I said, "Lee." And he goes, "My name is Lee too." And he goes, "What do you do?" And I said, "Well, I'm a carpenter. I used to be a firefighter. I'm an executive. And I was in the Marine Corps." And he goes, "You know who was a carpenter? Jesus was a carpenter. And that's what we're going to do here for you today. We're going to establish the foundation for the rest of your life." And I thought, "Oh, that's pretty slick. I'm going to follow you." And so 3 days into that, I remember just coming up with every logical reason I could to leave the program. And I remember he had talked about so many opportunities for me to navigate this with certainty and conviction. And one of those things that really was a hindrance to my development was I literally didn't know who I was. And in this industry, that is a common theme across I've been in the industry now for as long as I've been in recovery. And that's one of the most common things that I come across with people is they have no idea who they are. They come to our organization and they come to find that, right? And so coming from that deficiency, I started to look at this opportunity, and I had spent so many years throwing my arms up in victimization, and I didn't realize that life didn't happen to me, it happened for me. Again, I didn't take this traditional route to the industry, the one that you've taken, and God bless you for it, right? I took a different path. And when I finally understood that, I started to recall all of the events throughout the course of life that prepared and equipped me for what I do present day. The incarcerations and reentry programming, the sexual abuse and our trauma-informed care. I mean, there's so many things that we do through the organizational umbrella that I didn't know that I needed to navigate the industry, right? But when I came into the industry, that's where it really became evident to me that I was in preparation all them years in my descent into self-destructive behavior. I've taken my addiction and everything that comes along with it. I sold dope from 13 to 23. I was a drug dealer for 10 years. I made more money than both my parents put together. I had a home before them. I had bought a car, and I didn't even have a driver's license the first time I bought a car. But in all of these instances, I look back and I kept thinking to myself, I didn't realize I was constantly in preparation mode. And then when I came into this industry, I always remember thinking to myself, I had absolutely no desire to come into behavioral health at all. Like I wanted to continue. And if you pay attention to the model, I was a firefighter, a United States Marine, a carpenter. I was chasing masculinity. I wanted to live within the confines of masculinity so I could understand what it was like to be a man because I didn't grow up with one. And so I was constantly surrounding myself with people who embodied this persona that I wanted to have. And then when I came into behavioral health, I remember listening to people and I would offer suggestions or insight and they would, and then I started thinking about the entire theme of my life. Even as a little kid, I was the guy that other kids came to and talked to me about their parents getting divorced, their breakup with their girlfriend, or whatever the case may be. And I started to see this theme. And then when I came into this industry, I started to really acknowledge that all of these opportunities that have been presented to me were creating a foundation for me to exude the same quality and character that I was looking for, right? And so I remember at the end of this program, they gave me a little stipend of $100. And I took this stipend and I remember they let me go on pass. And I went out to look because you're supposed to buy like something to interview with or whatever you needed for clothes to go interview for jobs. And I went to the Salvation Army and it was Dollar Day. That's what drew me because I saw this big old thing on the window and it said Dollar Day. And so I go in there and when I get in there, I found this 3-piece suit, pinstripe blue, and I was like, oh, this is cool. So I took it into the dressing room and it fit me as if it was tailored just for me. And I was just like, I remember standing in there and I'm wearing white socks and I'm looking, they have the little window or the mirror in there. And I'm just turning and I'm like, how is it that this is $1 and it fits me perfect? And so I'm looking at that. And then I go out and I create the transaction and I said, so it's going to be $3. And they're like, no, it's $1 for the whole thing. And I was like, what, really? So I buy this suit, right? The next thing that came about was I needed shoes to go with this. And so I went across to Dillard's and I remember walking in there and I want you guys to go back to when you were a child, right? Do you guys remember the very first pair of shoes that you got? And if you're anything like me, you were looking for a specific pair of shoe and you were looking for that one shoe that was going to make you run fast and jump high, right? Maybe you had one of the little tabs in the front that you could have put a penny in, or it had some straps, or it lit up. And I remember I walked in there with all my aspirations and all my dreams because once I put on this suit, I was equipping myself for this journey that I was about to partake in. And I walked into this shoe department with that same vision in mind. I'm looking for the one shoe that is going to take me where I deserve to be, where life prepared me for. How I put on this suit and how I accompany that with this pair of shoes that I'm going to find is going to create the foundation for success. And I'm going to be somebody. And I remember going in there and I walked in and I saw this pair of Kenneth Coles. I took them off the shelf and I was holding them in my hands and it was just like the light came from somewhere and it shone on these shoes and I'm like fantasizing about all the great things that are going to happen when I put them on. And just like a little kid, I was looking at these shoes and I'm thinking to myself, I'm going to hit a grand slam and bring everybody home and they're going to chant my name. I'm going to hit the game-winning shot. And I'm fantasizing about I'm going to be in a business suit and I'm going to be a CEO. I'm going to be an owner and I'm going to do all these amazing things once I put these shoes on. And this guy interrupts this thought and he says, good afternoon, sir. Can I help you? And I said, yeah, can I get these in the size 9.5, please? And he looks at me and says, you got it, dude. He takes my shoes back there to shoe heaven where everybody's dreams exist. And I stood there and I continued to fantasize about once I put this entire outfit together. And he came back out and he goes, I'm sorry, sir, all we have is a size 11. That's the closest size we have in this. And I said, go ahead and bring it out. Because remember, as a child, when you found that shoe, it was never too big. You got all the warnings, it was all pre-established. You're gonna trip, you're gonna fall, you're gonna hurt yourself, they're too big. But you're so adamant that you knew if you had access to these shoes, great things were gonna happen. And so, like any adult with any kind of logic, I stood there and I thought to myself, how am I gonna make this work? So by the time it comes out, I already have in my mind, I'll get an extra sole, I'll wear 2 socks. Heaven forbid I need to grow my toenails longer. I'm gonna make it work, right? And keep in mind, that's the ingenuity of an alcoholic and a drug addict. You never in your life will meet an alcoholic or a drug addict that cannot figure it out. Never. You will never meet a meth addict who finds a bag of methamphetamine and says, oh man, I don't have a pipe to smoke this with. I guess I'll just save this meth for a rainy day. right? You'll never meet an alcoholic who has a challenge managing a corkscrew. They'll figure it out. We're built to win. And so when I was thinking about this and they came out and they brought this shoe and I put that entire outfit together, I remember I just stood there in this mirror back at my sober living and I thought to myself, I'm going somewhere with this. Fast forward about a week later, I'm outside of Native American Connections because I'm about to transition over to their sober living environment. So I'm in a 3-piece suit. It's 115 degrees outside. I'm on foot and I'm walking and I go to Native American Connections and I walk in the door and I stand there and I say, I'm here to get an application for a sober living environment. I just want to, fill out the paperwork and I turn it back in. And so this gentleman hands me the application and I walk out. And as soon as I walk out, I stand there and I'm looking out. And prior to that, I had not interviewed, but I got applications that I have Denny's, McDonald's, and somewhere else. I think Del Taco. And I stood outside that door and then I thought to myself, I wonder if they're hiring. So I went back in. And what I didn't know was that the gentleman that was behind the counter was the HR director and the woman that typically navigates that responsibility had gone out to lunch. So I go back in there and I say, excuse me, sir, I just was wondering, are you guys hiring for any positions? I'm new to recovery. I have about 6 months of clean time. And he goes, hold on 1 second. So he gets on the phone and he goes, hey, you got a minute? I got somebody here that I think you should meet. And I hear on the other end, she goes, did you hit a home run? And he goes, I think I hit a grand slam. And I looked at him and I had an impromptu interview in that moment and I was hired on the spot and I started on that following Monday. I stayed with that organization for 5 years. And my mentor, one of my mentors, Didi Yazzie, who was the CEO for Native American Connections for, I want to say 50 years. She became my mentor, but part of the reason why was because on my first day of orientation, she was in her office on the 6th floor and we're going around doing orientation, meeting new people and whatnot. And I went into her office and I went straight up to her and she was sitting at her desk and I said, one day I'm going to take your job. And I walked out. And then afterwards I got scared because I was like, oh, what if I get fired? But then later on, she thought it was funny. So the next orientation, I remember they came around and she goes, this young man, when I first met him, he said he was going to come take my job. And so it kind of became this thing. And next thing you know, 2 years into it, I'm working side by side with her up on the 6th floor. And she's mentoring me on how to navigate the industry. And good thing I didn't wait for her because she didn't retire for like another 20 plus years, I think. But I left at 5 years. It was one of those moments where I loved what I did, but I needed to know that this was going to go somewhere. And a lot of times we take life, we play it like double dutch, right? We're always like, it's not the right time. I haven't lost enough weight. I ain't got enough money. You know what I mean? But I took a leap of faith and I left. And I remember when I left, everybody was like, where are you going? What are you going to do? And I'm like, I have no idea. I have nothing lined up, but I'm trusting that I'm going to land exactly where I'm supposed to. And it was the very first time I did it. And when I did, I remember initially I was like, I have supreme confidence and faith. It's going to work out. Up until a month later, and I still didn't have a job and the rent was about due. And then I started panicking. And then I pulled it back and I said, nah, supreme faith. Rest in that. The next day I got a call and I was offered more money and a higher position with more responsibility and better benefits. I took that job and about 2 years in, I did the same thing. I started thinking to myself, what if that was a fluke? What if it was a one-off? Let me test my faith again. I went into my supervisor and I said, today's going to be my last day. And he looks at me and he goes, why? What happened? Where are you going? What are you doing? And I said, I have no idea, but I'm taking a leap of faith. And then I did it again. But this time, instead of a whole month, it took 2 weeks. And then after that, I did it again because I really needed to know. Maybe I just got lucky. And so the next job that I had, that same job, 2 years into it, I did the same thing. Went into my supervisor's office, told him that it would be my last day. But instead, this time, it wasn't me calling. It was people saying, hey, I heard you're not working over there. You want to come over here? Better money, more benefits. And it was like, good looking out. Constantly testing that faith. And people talk about faith a lot. They say they have faith, but are you willing to test it? Because when I would tell people this story, they would say, well, I could never do that because I have kids. I have a mortgage, I have a car payment, and I'm like, so do I. But I'm willing to test the limitations of my perceptions of faith because I know my creator got me 100%. There's no way I could take my addiction and everything that I've done in my life to the extremes that I did and still not die and come all the way over here and to present day be the CEO and the owner and be on the National Council board and fly all over the country speaking at different venues and doing all of the stuff that I do if it wasn't for faith. And that's why, you know, a lot of times in this industry, you'll hear the word hope thrown around a lot. And when it comes to hope, I'm one of those people that I always, you know, I don't like the word hope. Faith is different. Belief is different. Hope kind of like you throw it up in the air and you're like, oh, I hope she calls me. I hope I get the job. Faith is different. Faith will cause you to drop to your knees and pray. Faith will look at and allow you to evaluate your process and say, I believe not only in my creator, but I believe in myself and I believe in the process that I've established for my success, right? And so as I'm going through all of these things, you know, I'm constantly looking at that. And when I finally had that moment to where year over year, I'm duplicating success after success. And I just couldn't, there was a part of me that I constantly was waiting for something bad to happen because nothing ever good happens to people like me. You know what I mean? Keep in mind, I come from an indigenous community. I've lost 8 brothers to addiction. My mother raised all of us by herself. My father was vacant, abusive, alcoholic, just like I said, everything that you could have gone through, I've gone through and I've experienced firsthand. And when I started to come into this industry and I created this platform for myself, I started to think I didn't get here by myself. I stand on the foundation of my predecessors because their ceiling has become the foundation that I stand upon. And I have a responsibility for the people that come behind me to do the same thing. Can you imagine how influential it is that when I go back to my tribal community and people say, man, I knew you when you were like this. How did you go from that to this? And now you're a CEO and now you do this and now you do that and now you're doing, and to look at them and to see that when I talk to my son and I ask him, what do you want to do? One of his responses earlier on was like, I want to be a CEO, right? And it touched me, but I also told him, you can be whatever you want. I'm going to be proud of you, regardless of the decisions you make in life. And that's not the kind of upbringing that I had. You know, it was very, you literally come into this world with pre-established expectations, right? And when you do, some of you guys, I'm sure, are probably even named after the people that they wanted you to be like. And when you go left, instead of staying linear with that objective, they look at you and they say, oh, Nancy, you really let me down. I'm really disappointed in you, right? But imagine when you go all the way left and for people to look at you and even your mother, this woman that said, I will love you forever. I'll take care of you unconditional until the point that she's looking at you through a 2-inch gap in a hotel door and looks at you and tells you, do what you want. This is your life. I'm done. And closes the door on my face. And to think like every family member, every relationship I burned, right? But then you come into this and like I had mentioned before, the opportunity to cultivate identity. Most of the time when I make introductions with people, they come up to me and they say, hey, my name is so-and-so, I'm a student at NAU, I'm a faculty member, I have 2 children, I've been married for 5 years, blah, blah, blah. That's not who you are, that's what you do. It's very different. Identity is based and established on innate quality. Who you are will never leave your side. Even in the midst of my addiction and my most darkest moments, even to the point to where I tried to terminate life. When I came into recovery and people asked me, what's one good thing you can say about yourself? I had nothing, but then I had to stretch a little bit and I said, I'm compassionate. I care about people. And they said, what do you do that shows that you're compassionate and you care about people? And I said, I do this and I do this and I do this. And after a while, I started to look at myself and I started to think, I am care, I am compassion, I am love, I am certainty, I am conviction, I am security, I am safety. And I exude all of these qualities consistently on a daily basis for everybody that comes into our care. And that's what equipped me for this. So what I want you guys to be mindful of is don't judge people about where you meet them. recognize that they're an endangered species too, and there's somebody's daughter, somebody's son, somebody's brother, somebody's sister. There's somebody to somebody out there in the world. And it's time to treat them accordingly and to recognize that you have been given a gift to touch and to impact the life of the people that you're in close proximity to. And you have a responsibility. And these people are looking, they'll learn to care when you do. You know what I mean? When they know you care, they'll start to change the dynamic of how they see themselves in the mirror. And that's exactly what I needed. I needed to be in proximity of people that would go to the end of the earth for me. And I know I get it, like in regards to ethics and boundaries and all this stuff that through practice that you guys learn. But there comes a point too to where I know if you're in this room or you've been in this practice before, there's that one person, this one kid that you're willing to break the boundaries for because he needs it, because he wants it, because it's in you to do, right? And I test that limitation all the time. I'm a hands-on CEO, so you'll see me on the floor all day, every day. I know 250 clients by name, and they know me. When they come into our care, I take the time to read their profile. So when I meet them and I say, man, it must be cold in South Dakota. And they say, how did you know where I'm from? Because I took the time to review your profile before you got here, because that's how important you are to me. When I meet with people individually, they'll see my phone light up and they'll be like, I'm so sorry, I don't mean to take time. And I'll tell them, don't worry about it. You're the most important person in my life right now. I don't give a shit what happens outside of this room or this interaction. You are the most important person in my world. And you have no idea how it makes them feel like, oh. I mean, I even had this conversation just a minute ago with Ariel where she said, I don't want to burden you. I don't want to bother you. But at the same time, I have never told anybody that they're a bother. I have never told anybody, it's a little bit too much. You can stop now, right? But I want you guys to truly recognize that if people didn't do that for me, I assure you I wouldn't be here today. But there was people that looked at me and took the time to trust and to violate those boundaries, and to even like, and I know like if there was some people in here in compliance, they'd be like, oh my God, what do you, but people would say, hey, I know I'm not supposed to do this, but I'm so proud of you. You're doing so well. Here's my number. If you ever need anything, call me. You know, and I know they're taking a chance that I'm gonna continue to do well, and I will call if I need to. But with the license and with education, you guys spend years of education coming to school to acquire a degree and certification and a proficiency to do what you do, to sacrifice it potentially on one person. But I knew that. And so I respected it. But it's what I do today. Like even when I go out to the various facilities that we own, I'll go up to people and I hug them. And HR and compliance is like, oh my God, you can't touch. And I'm like, you have to learn how to treat people like people. They're human beings. Part of the reason why they're here is because they didn't have that. I'm an adult male in the process of evolution. I always say it that way because people run around and they throw terminology around like candy. I'm a man. But yet you're not responsible for your children. You're crippled by your addiction. You're inhibited by your anger, your tendencies, and your behavior, your mentality. So I always say I'm an adult male in the process of evolution because it allows me the capacity to continue to grow and to learn, right? And so I'm constantly teaching and reinforcing from a perspective of understanding that there was a time where I was lost, but when I understood what innate quality produced in me, I have a responsibility to give it out consistently and without reserve, to let people know that I care, to let people know that I love them. In my organization, it's not uncommon where a client will come up to me and be like, hey, what's up, Lee? How you doing today? I'm good. I'm excellent. I'm amazing. I'm spectacular. How about yourself? And they'll say, man, I'm doing amazing. Thanks. I love you. And I say, I love you too. And people will look at them and, oh my God, that's unethical. But okay, you're dealing with people. And an adult male looking at another man and saying, I love you, for you not to respond, it's crippling. Trust me, I know. I grew up that way. I grew up within the confines of masculinity to where I might not have had a father, but I had uncles who were in incarcerations, and they were the kind that instigated stuff, right? They would do things, and keep in mind, I had 8 brothers or 10 brothers before they passed away, and all of us together, if one of us did anything, my uncles would say, oh, you gonna let him get away with that? Oh, you gonna let him talk to you like that? And it was real quick to fight, so I am aggressive. But at the same time, what I wanted was nurturing and love and compassion and understanding. And when I got it and I put it together, I started to create a foundation of healing that embodied everything that people need. You know what I mean? And so when I was going through this entire thought process about presentation today, I just want you guys to remember you have a gift. And for whatever reason, you are appointed. And a lot of times you're anointed before you even given the task. You're given that blessing before you even realize the gravity of the responsibility that you have right here in front of you. And it comes from this place of like, not everybody can do what we do. But when you really honor and respect it for what it means, you touch the lives of people that will change their entire trajectory of life. You have absolutely no idea. And the great thing about it is that I've been, obviously, with the lifestyle that I've led, I've held the hands of people at the end of life, whether it be days or hours. And there's a common theme between them. They always want to know, did people know that I care? And did people know that I love them? And for myself and everybody else in this room, we don't have that problem because we do it every single day. I always say this, and my mom always gets mad at me. I always say, I could drop dead right now and I serve my purpose. Period. I do it consistently every day. I've taken my life to an extreme that people couldn't even imagine and come all the way over here to succeed. I'm good. I've lived, like I've actually lived. And I want you guys to just remember that at the end of all of this stuff, we have this tremendous responsibility to people to honor the gift that was given to us to bestow upon other people. And it is a tremendous responsibility because I even remember the times and periods going through COVID. I remember people would come to me, parents, and they would say, I want my son or daughter to receive care through your organization, but are they going to be safe? And without reserve, I would look at them dead in the eye and I would say, yes, I guarantee it. Because I had faith and I had tested it before. I know that I'll come through on the other side. And so even then, people got sick and people, we had to quarantine a couple of times, but nobody died and people got better. In fact, throughout the entire process, I grew the organization. When I first got to this organization, it cost $45,000 to $60,000 to come to this program. But when I got there, one of my stipulations was, I'm gonna introduce state-funded policy to this organization so people that look like me, that come from where I come from, and have the experiences that I have, can have access to an elevated standard of care. And everybody looked at me and they said, oh no, you can't do that. You're gonna diminish the value of this organization. You're gonna diminish brand recognition. Essentially, you're gonna taint this company. And I said, that's the only way I'll come over here. And so reluctantly they did. They allowed me to do that. And so people on an access policy can come to this organization where in the backyard of our house, we have a swimming pool, a putting green, a volleyball court, a sweat lodge, what do you call that? Pickleball. Yeah, we have all kinds of stuff. But I wanted people to know that this is what true healing looks like. You know what I mean? To be able to create the foundation that's conducive to the recovery process and an opportunity to take back everything that rightfully belongs to you. And so for me, and I'm going to touch on these slides real quick, but for me, it's just a matter of true understanding about the responsibility that I have to the people. And so when I look at these individuals that come in that normally wouldn't be able to afford to come to an organization like Scottsdale Recovery Center, I tell them this story and I let them know, I did this for you. Because you're just as entitled to anybody else to have this elevated standard of care and anybody else in the world. And I want you to see what treatment is supposed to be like. So real quick, I'll run through this. But there right here, we have the full spectrum of care, detox, residential, IOP, and several housing components up there on the top right. That is our Trulies. It used to be an Airbnb, but we house 46 individuals. It's a condominium complex, basically. And so our entirety of care, people always say that it's usually 30, 60, 90 days, but literally our employee pool is 30% former clientele because we prepared and we equipped them. And the great thing about it is I don't really have to train them because they were on the receiving end of services, so they know how to treat people. Then we just get them certified, fingerprint clearance, first aid CPR, the whole nine, and they're good to go. Next one. psych, primary care, nursing, we have it all under one umbrella. MAT, medication assisted treatment. We do all the case management and everything that case management entails. And I just have to say this real quick, case management, when I first got there, it was Botox injections, eyebrows. And because they were paying 45 to 60 grand, there was no oversight by any accrediting body. They were paying cash, so they felt entitled to say, I need to go get my Botox done, and they would get lip fillers in case management. But now we have true case management. Traditional healing components, the sweat lodge, talking circles. We have a great relationship with Native World Enterprise, who facilitates every tribal or cultural practice for every tribe in the state of Arizona. Individualized group sessions, EMDR, brain spotting, all that other stuff. And family workshop. The cool thing about family workshop is we do this every weekend. And once you're a family or you're part of the family network, you're in this for life. So even if your family member goes off and completes treatment and is 2 years clean, but then they start dating somebody, that family member can still come back and say, hey, they got a new girlfriend and that girlfriend drinks and he's in recovery. How do I manage it? They can come back. It's for life. Next one. Care Academy, this is what we got licensed last February. And so we, again, I want to say this too. The entire organization was established on client feedback. So when clients first came to the organization and we only had outpatient and sober living before it was classified, and they would say, hey, Lee, I love this program. I wish there was somewhere I could do my GED. Boom, mission accomplished. Hey, Lee, I love this program. I wish there was somewhere I could work on my resume. Boom, mission accomplished. Hey, Lee, I wish you guys had a detox because I was at this place and I didn't like it. It was bad. Boom, mission accomplished. So everything the clients ask me for is everything that I produce. Next one. This is our relationship with Mesa, GCU. You know, the great thing about the GCU relationship is that we got the clients, they didn't want to work with our clients because there was a high turnover and, you know, all that kind of stuff. But we got them to a point to see that we have long-term sustainability and maintenance and recovery. So they took a chance on our clients. So we now have 2 clients pursuing their master's degree at GCU. Auto Mechanics, Mesa Community College, and then Paradise Valley. Next one. Peer support, the Elevate program. These clients were coming to me and saying, my insurance policy is gonna term. I don't feel like I'm ready to disconnect. I don't know what to do. We created a peer operated program called Elevate so that they can come back. They come back consistently every Tuesday to guide each other, support each other, acknowledge each other, highlight the accomplishments and whatever, support each other through challenges. And it's a thriving community. Like we have this meeting every Tuesday. And there's at least like 20 clients that have over a year or 2 that come back just to chop it up with each other. Peer support certification, we have several classes that we offer. Next one. These are the graduates of the peer support program. 300 individuals certified since 2023. And we got the Attorney General's grant for the tribal community to house the displaced individuals that were impacted by the fraud. Homes for Heroes, we just got this one, so we're housing veterans in our program as well. They have access to the full spectrum of care. We have already got tremendous results with this one. And Health Justice, we got the entirety of the grant that's typically distributed amongst treatment providers, but we got all of it, so we have that entire structure of the organization. I mean, there's so much. I told you there was a lot. And I know I'm gonna leave stuff out. Yeah, the community reintegration, like all of this stuff, and I'm very adamant about this. When they talk about reentry and reintegration, it's kind of like an umbrella approach. What I want and what we've designed here is we're reintegrating people into the family, into occupation, into education, into community, into all these because they're all different and they're all very distinct. So this individual under that larger umbrella where it's, you know, reentry and we're gonna teach you all this stuff, I want you to go to work and then come back and say, like, my boss was disrespectful, like I felt like popping him in the face, because they're a whole different breed of people that come back with a very distinct mindset about how to interact with people. And so it's us intervening so that way they know how to conduct themselves in the appropriate environment. Next one. These are some of our partners, just a few of them. And we have so many partnerships. I think we're just highlighting at the time this group. And I think that's it. Yeah. So anyway, there's a lot for the organization. And again, just referencing that little cutout thing that I was saying before, the world needs you. And the great thing about it, and I'll go back to my initial statement, when we get to that destination, I'm gonna be grateful and I'm gonna be happy that we got there together. Thank you very much, ladies and gentlemen. Any questions? Okay. Anybody have any questions, any comments, anything?
Thank you for your wonderful presentation. I'm interested in whether you have services for teenagers or are they all adults?
It's all adults. But again, when those things start coming up, usually what I do is it's a lot of individualized feedback where people come to me and they say, do you do work with teens or do you do work with women? Prenatal has come up a lot. And so when we're having this conversation, this literally is starting to create some movement. One of the other big things that has come up with all the fraud that happened in Arizona, when I work with the tribes, for those of you guys that are familiar with the tribal complexities of how to develop relationship, it's very slow moving. And so one of the things, and I know you guys had seen it when I did the reentry, I developed a nonprofit in 7 months, right? Like just boom, one after another, everything that I needed to accomplish. With this latest effort, I got a build design, I got a foundation to offer up $2.4 million, and I got the architecture already, everything's already established to create sober living homes on tribal communities. And so for me, all I need is a tribal investment to say, put it over here. But again, it's very hard to do because there's lots of politics involved with acquisition of land and ownership. So there's a lot of work that still has to be done, but I accomplished that in 3 months. And so my point in saying that is that when I work with the tribal communities, they want to have meeting after meeting after meeting after meeting. There's no need. We can get there and expedite the process because in the meantime, while you're having these meetings, our people are out there dying. They're being exploited. They're being taken advantage of. They're going missing and murdered. And you want to have a meeting to discuss what the problem is? You know what it is. And I'm here to address that. I'm here to provide a solution, but follow my lead because at the same time, the reason why I always point that out when I'm working with the tribal community is because they take so long to do everything. And so when I come back and I highlight, I created this program, this nonprofit, got the status, got the logo, brand recognition, everything in a 7-month time period. What's your excuse? You've had years to do it. And they always want to talk about enacting tribal sovereignty, yet they don't do the things that produce independently what the people need. Sorry, I'm gonna get amped up a little bit. But anyway, going back to your question, when it starts to come up, I focus on it. And when it keeps coming up, it's kind of like creators telling me, hey, pay attention to this. The world needs you. You know what I mean? So you're the third person that's brought that up to me in, or the third person in 1 week. So it might be a thing. What else? Please take advantage of me right now. I'm here to answer any questions. And there's nothing that you guys can't touch, especially with the tribal stuff. There's always a lot of hesitation, like you don't want to be disrespectful, you don't want to say the wrong thing. It's an open platform here. So if there's anything that's been on your mind or you want to better understand or anything, now's your chance.
So do you get referred clients from Flagstaff, right? And they go down to Phoenix, don't they, and enter your facility.
Yeah.
So do you with Native individuals, do you believe that they need their own like cultural space, or is everybody fully integrated? Like, is there a separate unit for Native still?
Nope.
Everybody's integrated and there's just cultural services.
The reason why, because my boss, the owner of the company, came to me and she told me, I want a tribal track, a tribal program.
Yeah.
And I told her, I'm not gonna do that. And she said, why? And I told her, because when you're coming from a minority underserved population and you isolate us in this room and you see everybody else over there getting a service, you start to look at the deficiency or the inequity and you think, what are they getting that I'm not? And is this person that's leading this class or whatever, are they equipped the way that person is? And how come if that person is over there talking to them, is this person equipped to navigate the responsibility of their role and function. And so those are the kind of things that I was really, there's so many things that I kind of push the barriers on. So that is just full integration. There shouldn't be no separation. And I treat that with everything. And if you can imagine how difficult it was for me to go into Scottsdale and upend the whole thing, when they told me and they said, you're gonna essentially tank the brand recognition and the value of this company. And I said, what if I don't? What if I elevate the standard of state-funded policy and everybody around us mimics what we do? Sure enough, when COVID happened and all of these people that could pay 45 or 60 grand had to decide, am I gonna keep my house and pay my mortgage and feed my family, or am I gonna drop 45,000 on treatment? These other providers went out of business and I started growing. And so after COVID, other people, all the other providers in Scottsdale started doing the same thing. So, and you know, I don't like going back and telling people I told you, but it's those things again to where I have supreme confidence and conviction in what I do. And my vision is always 3 to 5 years out. I'm not looking downwards. And that's why when I'm guiding people, you know, a lot of times we have a tendency to look at look at what's ever happening. I'm already projecting. I already have a 5-year plan for the next 5 years. But it's these kinds of things that I think are super important to have open dialogue about, and to really, I'm getting into the political space. I spoke in Washington, DC. I'm going back again, I think in May. Yeah. So there's so many things that I'm doing that are, you know, and I have this. I remember the very first time I went down to the Capitol during the sober living crisis, and there was a senator there that said, I don't know why we care, because these Indians are gonna drink themselves to death anyway. And I was the only person, the only native in the room. And it took everything in me to not function from my anger and walk out. And there was a ton of things I could have said, but instead I thought to myself, if I say anything, it's gonna be like, oh, yep, see, aggressive native, savage guy, whatever. And if I leave out of anger, I take my voice with me. So I stayed. And at the end of it, towards the end of that conversation, they finally turned to me and said, well, being that you're the only Native American in the room, what do you think? Then I had the opportunity, and part of that conversation turned into a bill that we're actively pursuing today. So those are the kind of things that I have a huge responsibility to make sure that I accommodate the need for the people and be the voice. So yeah, you guys saw me kind of get a little heated about my exchange with the tribal community, but I'm like that with everything I touch. Because no matter what it is, there's a deficiency there. When you bring up teenagers, I know what it's like. You know what I mean? I know what it's like to have those experiences and want people to intervene on my behalf, to be my savior, to be somebody that's going to come in and tell me that things are going to be better. And that's all I want to be for all of humanity. What else?
Well, first of all, Asmali, for sharing your story with us and just all of the hard work that you've been doing in advocacy. It's really inspiring to hear. So thank you for sharing that. I saw that you guys do sweat lodges. I was curious what other types of cultural traditions and healing you're integrating into your services.
We do the labyrinth is what I was trying to remember earlier. The labyrinth, sweat lodge, talking circle. We kind of introduce well variety, but not a whole lot, because there's so many platforms that we can utilize now, so they're more open to a lot of different opportunities. And then like I said, we have a great relationship with Native World Enterprise. So what they do is they have a network of providers from every tribe in Arizona. So if I was from Navajo Nation and I need a specific service done, I work with them, and then they send somebody down. So to give you a quick example, we had a young lady who was in our care. She was about 6 months clean at that time. And then her two of her brothers had died in a vehicle accident, alcohol related. And she didn't want to go home because she was afraid she was going to drink again and all of the stuff that was going on emotionally. So we had a provider come down there, provide the ceremony. And then afterwards, you know, she felt better. And then that was 2 years ago. She's 2 years sober now. What else?
You reintegrate your clients into the family unit. You have continued care for the family unit.
Your family for life. Once you engage in that family workshop, you can come, whether it be 2 years, 5 years. People sometimes just come to get a refresher on, like how I gave the example earlier. Like, my son is 2 years clean, but his new girlfriend drinks. Like, what do I do? Should I be worried? You know, that kind of thing. So they come back all the time. Your family for life. Ladies and gentlemen, it's been my honor, my privilege, and my pleasure to be here today. So you guys have a wonderful day.
Okay, I believe we have about 5 minutes until our next scholars presentation.
All right, good afternoon, everybody. So we do have a pretty tough act to follow, but I think we'll keep you pretty entertained for the last presentation of the day. My name is Kiera. I'm an OT student. I'm actually in my last few weeks of my OT program, so I'll be done very, very soon. And with me, I have Nico.
My name is Nicolo Ianello. I'm a recently finished Doctor of Physical Therapy student.
My name is Nancy Collecton. I'm a clinical psychology student.
Okay. These are our mentors, Dr. Alma and Dr.
We need to introduce ourselves. Yes, okay, yes. Dr. Mo Marks and Dr. Rogers are our mentors, and we'll talk a little bit more about them later. So our project was measuring the effectiveness of a Crossroads Wellness Program. So this is a quick overview of what we'll talk about today. But before we get started, we'll talk about our community partner. So our community partner was Crossroads, and they're located in several locations all across the Valley. They have inpatient and outpatient services for individuals currently in substance use recovery. So they focus on relapse prevention, trauma recovery, and overall wellness. They like to prioritize a holistic approach, combining traditional therapy, nutrition education, and exercise. So at the location that we were at, the Pure Hearts location, they had a gym because they are trying to incorporate a wellness program into their recovery. So what that looks like is a 3-hour treatment session. And for the last 60 minutes, they go into the gym and they're released to do whatever kind of physical activity they choose to engage in. So the purpose behind that is to reduce stress, improve sleep and mood, and to strengthen their overall well-being. But before we can talk about the program that we were assessing, we have to talk about substance use recovery in general. So recovery, research tells us that substance use and addiction are influenced by a person's environmental, genetic, or personal factors. That recovery is most effective when using a whole person approach that addresses multiple areas of wellness. And those areas of wellness include physical, emotional, social, spiritual, occupational, intellectual, and financial health. And that self-regulation and self-efficacy help individuals change their behaviors, maintain sobriety, and that treatment programs should prioritize strengthening these skills to support long-term recovery. As far as physical activity, I think all of us in this room can think about why that's important for everybody to engage in. But for recovery specifically, it reduces cravings and supports sobriety, improves mood, resilience, and overall well-being, and decreases depression and anxiety. So our objectives for this study were to evaluate the effectiveness of the Crossroads Wellness Program and to determine whether the program successfully enhances traditional behavioral group therapy, and to examine the impact of supplemental nutrition and physical activity education on supporting long-term recovery, and to lastly determine whether or not these wellness strategies can be sustained beyond the program.
So at Crossroads, it is strictly an outpatient substance use disorder program. We were approved to work with up to 50 individuals. Can anybody not hear me?
It's best practice to use.
Okay. Because I don't want to be too loud. So it's strictly an outpatient substance use disorder program, not substance use. We were approved to work with up to 50 individuals for our study. Crossroads only works with adults, so all of our participants are 18 and older. They do have a wide variety of ethnic backgrounds, ages, and genders in the program, so we do have a pretty diverse sample in our program, in our study. And all of the people who participated in our study had to be actively enrolled in the program. They couldn't be recent graduates. Each of our participants were asked to complete several different types of surveys. We did have a demographic survey asking for some standardized information about each of our participants. And then we had another survey that was a pre and post survey. It had 17 questions on it, asking them questions about their thoughts and actions towards physical activity and how they were incorporating that in their recovery, how comfortable they were in engaging in that kind of behavior on their own. And they used a 5-point Likert scale to rate their responses to that. They should have taken less than 15 minutes to complete a fairly short survey for them. I provided training to the Crossroads staff via Zoom meeting so they could administer the surveys for us during their regular meeting times with clients, so it wasn't disruptive to their regular programming. And they were able to collect the data for us, which we then analyzed. So a little bit more information there about the types of questions that were on our survey that had the 17 questions on it. But yeah, the idea is towards physical activity as a coping mechanism and their feelings of self-efficacy using it.
So we analyzed our outcomes to determine whether or not physical activity actively supported their recovery or not. We utilized paired t-tests on our longitudinal data to determine if the differences we found were statistically significant. We ended up having 2 data sets collected about 4 weeks apart. Of 50 participants we had in total, only 14 were able to complete multiple surveys to allow for longitudinal data to be collected. So we had to kind of pivot, and we analyzed data both as a cross-sectional and also as longitudinal sets. Of the 50 participants who completed at least one survey, their mean score, all of these questions were out of 5, where 5 would have been a strongly agree, 1 is strongly disagree. The mean score for exercise self-efficacy questions was a 3.8 out of 5. So participants tended to lean more towards the agreement or the positive side of those questions. We did end up using reversal questions where the question itself would be negative and therefore a disagree with that would be a positive response. But we took that into account when analyzing and made sure to reverse that. Participants also reported strong agreement that staying active supported their recovery, and no participant rated their agreement with that question less than 3. So everybody was at least neutral, if not actively agreeing with that, with the average being in between that agree and strongly agree. And again, participants agreed and strongly agreed that their confidence in being active increased after they started the wellness program, and that they were satisfied with the total program. And again, the lowest response was a neutral for those statements, so nobody disagreed with those items. For our longitudinal data, we found some interesting things. There was a slight decrease in exercise self-efficacy over the 4 weeks. Out of 75 points total, there was an average decrease of 1.5 points or 0.2%. And we also found a decrease in confidence in program satisfaction of out of 10 points, 0.79 points. So that's an 8.6% decrease. And with our paired t-tests, we did find that the decrease in program satisfaction was statistically significant. However, the change in self-efficacy was so small that we couldn't deem it significant in any way. So the cross-sectional data indicates initially strong perceived benefit of physical activity for recovery, especially with how people felt first starting the program, strongly agreeing that they felt satisfied with the program and that it's making them feel more successful. The longitudinal data showed no changes in their self-efficacy and decreased satisfaction and confidence, but it's important to remember that they're going from a 9 on average on those questions, because it was 2 questions, so 10 total. So a 9 out of 10 total to an 8.2. So that's moving from being right in between agree and strongly agree down to more of an agree level, which is kind of pointing that positive perceptions may decline over time. People can go into treatment, really feeling positive, like, yeah, I got this. And then 4 weeks in, they're like, yeah, I still got this, but I'm realizing, I have work to do. And the findings also differ from our literature review, which we expected to see improvements in self-efficacy with these structured programs where there was no statistical difference in our study.
So like with any study, we had some limitations and some challenges. Our IRB process was not as streamlined as we were hoping it was going to be when we started this process. And part of that could have been because we ourselves are part of our challenges. As well as being graduate students, everybody on our team has another significant role. We have a soldier, we have a new parent, and we have a university professor. So trying to balance that with our clinical loads and our class loads, and now we're going to do a study on top of that. We had a hard time all coming up with common times that we could all meet to work on everything. So that probably contributed to slowing down our process just a little bit. We were able to maximize our sample size, so that was great that we were able to get as many participants as possible, but our hope had been able to collect data over a longer period of time. But due to the length of time it took to get through IRB, we were only able to collect data for a month instead of for several months like we had hoped to. And part of that involved us having to eliminate the focus group we were hoping to have at the end of our study to get some more qualitative data from the participants and get more of that real lived experience from them to let us know how this program really applied to the life instead of ticking off boxes on a survey. So if somebody were to want to repeat this study, or if we were going to change a thing, even without doing a focus group, if we'd have the opportunity maybe to do some exit interviews with the participants, that might have been able to get a little bit more qualitative data that way. Obviously, we would want the study to cover a longer period of time instead of just a month, because participants would probably have a more dynamic change if we were getting their responses over a 6-month period, a year period, as opposed to just 30 days, and more of that qualitative data. That really just tells you the lived experience of people who are going through this process.
That concludes our brief, but before we wrap this up, we do want to send a special thank you to Dr. Momartz and Dr. Rogers and the Pure Hearts team at Crossroads for helping us pull this project together. So thank you guys very much. And now we'll open the floor to any questions.
Oh, go ahead.
Oh, I didn't mean to. But I'm curious about the problems with the IRB. I'm on it, so just I'm on there. Yeah, I am curious about what happened there.
So it seemed like, and this wasn't a problem with IRB as in the IRB was doing anything wrong, to be clear. But getting our study approved, there were lots of little things that had to be changed, and we'd resubmit. It'd take, another week or two, and then, change these 2 things, and another week or two, change these things. And we ended up going through, I think, 4 different revisions at least. Which, a lot of the time was simply waiting to hear back about what we needed to change. And then at the end of it, we were approved, but we were approved with conditions, which meant we had more revisions to make. And then we had the conference coming up, which we needed to, fit our data collection in between, and then also have time for data analysis. So I think when we wrote IRB, we're not criticizing the IRB. We're saying the process of being approved by IRB took longer than we first anticipated.
Yeah, so I guess I guess that's what I'm kind of driving at. Is there a lesson learned in there anywhere?
Absolutely.
Okay.
Absolutely. So I think one of our lesson learned for sure is check twice, cut once. You know what I mean? Measure twice, check once.
Yeah.
Ensuring that our information is accurate and that we are saying the same thing multiple times. So one of the big things for us was where we were going to store our data, and just the difference between checking a box that says on the Atom software versus we're going to pick them up in person and shred them and keep them on the PBC campus. IRB is strict and they have to be. So measuring twice, cutting once is our lesson learned for sure with that, and trying to be as proactive as possible with submitting our application. Because like Nancy said, everyone in the program has multiple commitments, but I know I was going to Australia for 2 weeks in the summer while we were in the middle of trying to figure out what we were going to do. So yes, making sure that we are proactive with that, because like you told us earlier, there are real people on the IRB board. So they have real lives as well. So getting it in sooner. And so we do have to make those changes. We'll have the time to do so because we actually didn't get our data back until last Friday.
Oh, geez.
Yeah, so it was a very quick turnaround. And so like some of that could have been mitigated on our end. But you know, you live and you learn.
Yeah, as long as we learn, I think that then it's all still a good experience, isn't it?
Absolutely.
You know, yeah, I agree.
To be clear, she was in Australia in service, the US military.
Yeah, I wasn't having
not on vacation.
Yeah, I was not having fun. I was working, but that, I mean, one person of your team being gone, it obviously affects your team for sure.
Yes. So I had a question. So I have an IRB, but I have another question, not IRB. So when you were asked to make changes, and I can see where sometimes I've noticed that, you know, it's not consistent across, like your consent form has a slightly different version from what you say in your narrative, and then they catch that, you know. So, but every time you got changes back, were there some new things they found, or was it always related to the old things that they?
I would say they were new things. It seems like they would catch one big thing and we'd be like, okay, we'll fix this and we'll make sure this is right. And then we'll submit it. And it's like, okay, yeah, you did change it here, but you didn't change it in the paragraphs a little bit later down on page 4.
No. So what I mean by a new problem.
Yeah.
Yeah.
We also had that. For example, we had a lot of struggles figuring out how our data was supposed to be stored. And you know, originally we were planning to do one plan, which did involve the Atom server, but then the IRB informed us that we were classified as level 4 data due to the study population. So then we had to figure out the Atom server, but then getting the documents from the Crossroads campus to the PBC, where we uploading to encrypted drive and then onto the Atom server, and then we're not allowed to do, you know, we're not allowed to keep it on our personal laptops, so we can't upload it to our laptops and then to the server.
A lot of complications.
Yeah, and there were definitely times where we would fix one thing and then a new issue that wasn't that would come up.
Yeah, that's the part I was.
Yeah.
I think
So a bit of both.
one thing I want to add, which was really interesting this year, we used a very similar model to the study design that we did last year with a different project with Crossroads. But what the IRB was requesting, or even the level of data that they said it was, and the use of atoms was very different, even though I think when you look at the two studies, they were very similar. So I think that was a big challenge. They had kind of a model to go off of, and so we thought we were going to get through it like that. And whoever was reviewing it, I'm sure, saw other things that maybe the other person didn't catch. But shout out to Kit, who is amazing.
Yeah.
So really kind of helped us in the end. So
I mean, it's like committees, right? It's like, yeah, it's even like submitting your manuscript, right?
Yeah.
You can even get one person say do this and the other person say do anything but that. You know, it's just two different people.
I think, Julie, this is the first time that, in my experience, that we've had a CCART project that has been deemed a level 4 high.
That seems weird.
That was the part that kind of threw Oakley and I for a loop. So that may be something that.
And it doesn't seem like wildly risky data that we're taking. Like I'm looking at that and thinking, what?
Yeah.
So there must have been something in the description that triggered that, and they'll back up if you say, "Well, I said that, but I said that by accident."
We've had some conversations with them too, written and oral. But we're not quite sure what deemed it that level.
That guy's super sensitive.
Yeah. So if you find out, let us know.
I could log in and
please do.
It could also be, we did try to collect demographic data. However, out of the 50 participants, only 6 people ended up filling out demographic surveys, which didn't give us a lot to go off of, but those included questions like race, age, their full name, the drug that they had used that they were in recovery for. So maybe that portion was what led it to be classified higher. I do remember for a week we were going back and forth on them like, hey, can you elaborate why it's so considered such high level data?
And they just didn't respond, or
we never really got a straight answer on what specifically made it a level 4.
Because if we knew that we were asking the drug of choice, we could have adjusted on our end.
Or it could have been a cumulative of.
Right, but we're not.
Right,
Yeah.
sometimes you just cross the line.
Yeah.
Okay,
Yeah.
I'll ask my other questions, so get off IRB. My final question is, with exercise, there's a plateau effect, and I was wondering whether you've seen that in the literature and how that, because of the efficacy decrease, the first couple, everyone's really excited, and you said that, I think y'all mentioned that, yeah. But I was talking with the plateau, and if you've seen that.
Yeah, so two things. Firstly, the decrease was in the satisfaction and comfort due to Crossroads. So we had two questions at the end. One was, do you feel more confident in exercise after starting at Crossroads? The second one was, are you satisfied with the Crossroads program? Those two questions were the ones that had those decreases that I mentioned in the slide earlier. So it's not as much as an exercise decrease as it was with the program. But again, it wasn't saying that they were unsatisfied, just that they became less satisfied, maybe, like I said, as they realized they have stuff to work on. The other thing is these exercise sessions were very open floor. They weren't leading them through, as I understand it, they were not leading them through like, okay, we're gonna do 10 jumping jacks and 10 sit-ups. It was, hey, you're in the gym, do some exercise of some sort. So you would see people on the treadmills or like doing the stair climber, you'd see people maybe lifting weights, and then you'd see people like laying on the floor doing what they would say yoga if you asked them, right? So the fact that this wasn't as structured as it could have been could also be the reason that we saw some people going up in self-efficacy, like, yeah, I feel like I could do more exercises better. And then some people are like, no, I haven't really gotten any better at exercise.
So yes, in the research, we did not see anything about a plateau, which is why we were kind of shocked by the decrease. But when I went to Crossroads to witness one of their sessions, there was a lot of free roaming going on. So when I talked to the staff there, I talked to them and some of the participants about if they would like an actual structured class. But with that comes someone who is the education to teach people how to work out. Because yes, we can all go to the gym right now and do what we want to do, but if someone gets hurt under my education, that's a liability, right? So, and then also exercise looks so different. Like we all get joy out of doing different types of exercise. So if they were to structure it to be just Pilates or just yoga or just weight training, then what would that do for the clients that don't find purpose in that? So.
The only thing I'd add to that is at the time we started our study, they didn't have a personal trainer on staff. And that was something they were actively trying to recruit somebody. So I can see adding that person to their team is going to make a significant difference because they would have somebody who has the skills and knowledge to be able to teach instead of like, oh, we'll put a little post-it on the wall and you can do this at this station and you can do that at that station. Somebody who would actively lead people like a trainer would.
Anything else? Well, that concludes our brief. Thank you so much.
All right, since I have you all in here, if you could please take a couple minutes to fill out our ABRC evaluation. And I know some of you probably filled this out last night, but think about today just in a little bit of different context of what you heard today. And so feedback from today's activities would be great. And if there's another maybe research idea or something that we can turn into a conference or a workshop, that's really, really what I'm looking for. We get so many amazing ideas out of these conferences, especially this one. I think this is our 5th annual CCART, but we've also done 3 workshops for the past 3 years around culturally centered addiction research. So next year, I don't want to count my eggs before they hatch, but we are looking into alternative therapies for things like PTSD and drug addiction using psilocybin and other forms of alternative therapies. So just things like that. If you have any type of idea, I'd greatly appreciate it. Thank you so much.
And by the way, all of you in this room can fill it out, parents, visitors, students. So please, it's really important, right?
Yes.
Yes, so please. Well, thank you all for doing the survey. I just want to make a couple of announcements. Again, thanks to all our presenters. Regardless of when you got IRB approval, collected your data, you analyzed it and presented, you have done an amazing job, and I'm always so impressed by how you pulled it together and the meaningfulness that you've added to the project, and and the importance of the work you're doing. So thank you, and give them all a big round of applause. I also want to thank our presenters from yesterday. Many of them are here, so thank you. In fact, I think you're all here. So thank you as well. We've learned so much, and really exciting. And for me especially, I was thinking, wow, I'm getting to go do this full time now. So this will be fun. So thank you, Liz, and thank you, all of you, Sabrina, and where is Ariel and Oakley, and some of you came long distances, so we really appreciate it. Lee's story was amazing. It brought back a memory, which I haven't thought of for years. I was probably 22 at the time, and I quit my job because I really wanted to get into teaching. I had a master's degree, and so I quit. Well, of course, I was in a little different position. I was still living at home. My parents were supporting me. Working at that time was pocket money, even though I was getting a salary, which my parents let me do. And I was just sitting at home, lying on the couch, like, I really want to teach, but I don't have a job. And anyways, just kind of lying there, and the phone rings on a Friday evening, and a former professor calls me and said, hey, I have a 3-month vacancy. You want to come and teach for 3 months? And I said, sure, got nothing else to do. So that was my first teaching job. And then the last week of that job, same professor calls me and says, hey, there's another vacancy in the college. This is in Bombay, so there's colleges every block. You want to teach there? I said, sure. Yeah. That was totally out of my reach, meaning the topics were stuff I'd never really covered. It was loosely connected. It was social work, actually, but loosely connected to what I studied. But hey, I can read a book and prepare, so did that. Anyway, Lee's talk really touched me in ways like having faith, like this is what I wanted to do, and then doors open. So, want to also remind you that this evening we have a graduation reception. All of your friends, family, neighbors, whoever's wanting to come, and those of you, if you don't know, please come, join us, enjoy the celebration. It's at the High Country Conference Center, starting at 5. It's open from 5 to 7, but the main part of the ceremony will be done before 6, because I'm heading out at 6 because I have another ceremony to go to. So please join us and celebrate our graduates, celebrate our students who've done our scholars who've done such an amazing job. And our mentors, faculty mentors are going to be there, everyone connected with the project. So come by and have fun, and our provost is coming by too. Cool, thank you. Thank you, congratulations. Thank you. So we are a little bit ahead of schedule, which is a good thing. The cohort 4, those of you who are here, will head to room 155 for the kind of post-program evaluation. So please follow Amy, or is Amy there already? Yeah, please follow Amy to room 155. When you are done, you can come to the room we met this morning for the final research integrity training. So whenever you all are done, I'll be there, and so will Dr. Roddy, and we will complete that part of the training. And if you get done a little early, then you get a little break before the, well, look at the schedule. I'm sure I'm missing. What else is there after? RCF, that's it. Yeah. Then you get a break, and at 5 o'clock, meet us at the High Country. And so this does conclude the formal part of the conference. The next 2 things are very cohort related. And then we meet back up at 5 if you can join us. So thank you everybody for being here. Thank you for everything. And special thanks to our organizers for the wonderful food, Nick. That was my first time eating that menu. And Shannon and Amy and our communications. I know Beck has left and sorry, I can't remember everything. I'm sure you're gonna do a great job communicating what happened today. So thank you all. So bye-bye.